So good morning, everybody. I'm Ali Fatemi from the Kennedy Krieger Institute. We have, I think this is just for the purposes of online. So I think we need to be loud, or is there actual? Am I supposed to say something more? Test, no, okay. Just speak loud, yeah. So, yeah, we have a pretty packed agenda. So we're gonna take a break around 10:45. But other than that, this will go all the way till 12:30. And this is a session focused on ALD and AMN specifically. First, I just want to thank everybody for being here. And it's exciting to see people in person again. And I also wanted to just acknowledge all the loss that we have incurred, family members, friends in the last couple of years due to the pandemic and due to this disease. So unfortunately, that's still happening. You know, one of my patients just passed away a few days ago. And I think that's why we have this session. So we're really trying to move this field forward. And I think a lot of things have happened despite the pandemic. So that's, I think, quite exciting. And within the field of the leukodystrophies, I think ALD is the one where the most is happening. So, you know, despite all the burden that we have, I think there's also a lot of progress being made. So that's all I'm going to say today. I'm going to stop. And our first speaker's flight got canceled. So he's stuck in Baltimore. So Dr. Jay Raymond is going to kick off together with Stefan Kemp and talk about newborn screening first. And then we're going to move towards standard of care guidelines and so on. So Jerry, just get started.
Okay, thank you very much, Ali. And it is a pleasure to be presenting. I just wish I could be there, but unfortunately I'm not. I'm also going to go pretty quickly because I had passed over some of my time to Dr. Kemp, who's going to be much more interesting than I am. But I'm going to start talking about newborn screening and adrenal leukodystrophy because in some sense, that's where it all starts. Okay, and I'm not advancing my slides. Let me try this. There we go. Okay, so this is what adrenal leukodystrophy is. It is an X-linked disorder and results from the defects in ABCD1 and changes peroxisomal beta oxidation of very long-chain fatty acids, which accumulate. And ALD can present with several different presentations, but the asymptomatic one is where we're focusing, which is everyone at birth and then declines with age. And what we're really trying to hold off here is monitor for adrenal insufficiency and cerebral disease. These asymptomatic individuals used to be historically identified because they come to attention because of family screening. You know, we identify some individual with an elevation of very long chain fatty acid, and they usually would be presenting with adrenal insufficiency or childhood cerebral disease, but they would have brothers and uncles and things along these lines, and we would do expanded newborn screening. And then that led us to newborn screening in general. And we at the Kennedy Krieger developed a methodology using dried blood spots and tandem mass back in 2006. We did a bunch of studies to determine sensitivity and specificity. And I just kind of then figured it would just take off. Little did I know much about the political landscape of newborn screening. But it took Elisa Seeger to get Aiden's Law passed in New York, and Elisa's speaking this afternoon, and I'm sure will talk to us again about her efforts to make this happen. So newborn screening started in New York in the end of December of 2013, and then it got added to what we refer to as the RUSP, which is the Recommended Uniform Screening Panel in February of 2016. And our aim has always been to detect asymptomatic individuals and begin surveillance. I'm happy to report that all of these green areas are now screening for ALD. One of the things that's a little hard for people to realize is that newborn screening is determined at the state level. So if your state is one of these green states, congratulations, we are now screening for ALD using newborn screening. If your state's one of these red areas, which I'm unfortunate to live in, it is proposing to get started. And blue states are kind of ramping things up. And now we're also looking at you, North Dakota, South Dakota, Mississippi, and Louisiana, because you need to begin ramping up in some way, shape, or form. Okay, but what happens after this baby is identified? We will make contact and coordinate. And what I tell states is, and particularly the state newborn screening programs, is that they should use their standard protocol. So each state has its own little nuances about how they contact the pediatrician, what the next steps are, where they see the baby. But the infant really does need to be seen in 1 to 2 weeks following that determination. There's no need for emergency evaluation. So in newborn screening, we do have some disorders where we need to see the baby immediately. We identify this baby, we need to see it immediately. This is not one of these situations. And we need to determine, though, if there are other at-risk males in the household. We then go on to confirm the findings. We look at the very long chain fatty acids, the very accurate males. We usually throw in DNA testing, looking at ABCD1. And unfortunately, as you'll hear in a variety of talks, there's a lot of variance of uncertain significance, or VUSs. And once again, as many individuals know in this disorder, what your genetic change is does not predict what form of disease you're going to have. So it does entail surveillance for all. So what kind of surveillance do we do? We're monitoring to prevent and treat the manifestations. So we're going to look at adrenal insufficiency and childhood cerebral disease. The adrenal insufficiency can occur at very early ages. It usually develops over time, but it can start pretty early. So the earliest reported patients in the literature is about 5 months, although Molly Regelman has said she's seen someone who's around 3 months of age who had begun to have some adrenal insufficiency. And I'm aware of a boy who died at 22 months of age of an adrenal crisis. Fortunately, there's guidelines, and while this is a very complicated slide, the take-home message is at the top, and that any male we've identified with adrenal leukodystrophy through newborn screening or some other method really does need an urgent referral to a pediatric endocrinologist. And this is in their literature, so they're very much aware of this. The other thing that we're trying to prevent is childhood cerebral disease, which occurs in approximately a third of individuals. These are boys with initially normal development, onset between 4 to 10 years of age, with very subtle symptoms. And the MRI can look like this, with this symmetric bilateral hyperintensities with a garland of enhancement. And the peak incidences is, again, between the ages of 4 to 10. But what's important to realize is that the initial MRI is normal. So you don't just wake up one morning with an MRI that involved. So the early changes on MRI are fairly subtle and come on gradually. And so when you see an individual with where the arrow is pointing with a hyperintensity here, they're going to have a completely normal neurologic exam, normal neuropsych profile, and it progresses over months to more involved disorder. And that's where we can act. So what kind of surveillance? And I think we're going to be talking about further guidelines, but initially we're going to be talking about counseling and confirmation, and then we begin endocrine monitoring, and then neurologic monitoring with brain MRI starting at approximately 12 months, and then every year to about 3 years. And then we like to do them every 6 months. Yes, we could probably stretch that out a little bit more if your MRI is being looked at by someone who's an expert in the field, but not everyone is getting that level of care. And so we really do not want to miss early MRI changes. We have treatment. The adrenal insufficiency is well treated with adrenal replacement. And then also for early childhood cerebral disease, we have hematopoietic stem cell therapy or bone marrow transplant. And there has been ongoing work in getting gene therapy for those individuals who may not have a matched sibling donor or a good match for bone marrow transplant. So we'll also hear about bone marrow transplant a little bit later this morning. One other thing that sets adrenal leukodystrophy apart is that it's an X-linked disorder. So it's important to get what we refer to as a family history or pedigree and test other at-risk family members. So while it's typical for, to identify a boy, you may identify his mother, and the boy is that little square we see here. Rarely does someone appear in isolation. They usually have aunts and uncles who may also need to be tested, as well as grandparents and cousins. And so you sometimes open, quite honestly, a can of worms that you just now need to help the family seek out and test other individuals. It is, once again, an X-linked disorder. Women are carriers, and although may have symptoms, males can be at risk. And we're always going to be identifying other family members at risk. It sometimes clarifies neurologic and endocrine diagnosis in these individuals. You do need to be aware that 5 to 7%, kind of 5 to 10% of women may be new carriers for the condition, although rarely we also see a new male affected member of the family who's the only affected member of the family. And finally, I just want to talk a little bit about off-target determinations, because in the world of newborn screening, this is a big bugaboo. No one wants to be identifying individuals with other disorders that we can't be treating. Well, we are going to identify other peroxisomal disorders, and while that's an off-target, all of the families with other peroxisomal disorders, whether it be the Zellweger spectrum disorders or the single enzyme disorders in peroxisomal beta oxidation, have supported this newborn screening. They're aware that their child's going to be identified, and it's not going to mean as much as it does in the ALD world, but they are fully supportive of this. And so if anyone says, well, you're going to identify others, yes, you are, but everyone to date has been very supportive of that. And finally, I just want to highlight, since again, you're very likely not going to be meeting, if you've been identified through newborn screening, with an ALD expert immediately. I go around trying to preach to the geneticists, who are oftentimes the first people seeing them, is that how to counsel families. So we want to be providing factual information. I give an overview of the condition. We need to obtain some family history. We determine the genotype and the degree of biochemical abnormality, but these are not predictive. I outline the surveillance, and I discuss the treatments that are available even at that initial session, and we do it again and again. And I think it's very important that as we as practitioners acknowledge the anxiety of monitoring and not knowing. Some of these males we identify, some of these boys we identify are going to turn out to have cerebral disease, but not all of them. And I like to emphasize during this period of time, my goal is to keep the boy healthy. And while I've introduced some uncertainty into the family, it is our goal that I never want to see someone have a catastrophic adrenal crisis or be blindsided by childhood cerebral disease if we can prevent that. And I think that is my last slide. And I will stop sharing at this point and turn off my camera and mute myself unless there's any questions.
Thanks, Jerry. I'm thinking maybe have Stefan present first, and then do a quick round of maybe 1 or 2 questions. We have a whole discussion session also at the end of before the break. So thanks.
Check, check. Check, check. Check, check.
Good to go.
We can hear you now.
Hi, Jerry. So ALD is a monogenic disease. So all patients with ALD have a pathogenic variant in the ABCD1 gene. And I'll go into that a little bit more detail. And there's elevated levels of very long chain fatty acids. So that's a fact. However, the clinical presentations of patients is unpredictable. So males can develop adrenal insufficiency from as young as 5 or 6 months of age. We just heard that there's even a boy at 3 months of age. Boys are at risk of developing cerebral ALD, but not before the age of 3 years. And it's about 1 out of 3 boys before the age of 10 years. And the adrenal insufficiency is about 1 out of 2 boys before the age of 10 years. And in adulthood, all males and about 80% of females will develop a slowly progressive spinal cord disease. And for that, there is no treatment. But for the adrenal insufficiency and for cerebral ALD, there's treatment, but for cerebral ALD only if it's caught in time. So there's reason for newborn screening. So as I said, the disease is caused by a very pathogenic variant in the ABCD1 gene. And this gene codes for the ABCD1 promoter. I think I have a, wait a minute, sorry. Normally I have a laser point. Yeah. So it encodes the ABCD1 transporter, which is a transporter of very long chain fatty acids that need to be transported into the peroxisome for their degradation. In case there's a mutation in the ABCD1 gene, there's a block, so it's closed. The fatty acids cannot enter the peroxisome, and the levels go up in the cytosol. So this is a cell. I'm sorry. So the levels go up, and they're made even longer until C26. And there's a storage of these fatty acids, fatty acid deposits in cells and in organs, and that causes the disease, and specifically in the central nervous system and the adrenal gland and the testes. But already in 2004, Hugo Moser at a newborn screening meeting in the United States proclaimed that ALD would qualify for newborn screening because of the adrenal insufficiency and the cerebral ALD. Everybody agreed, but it was not possible at that time to screen for ALD in newborns because there was no biomarker. There was no way to detect the disease measuring many samples from many newborns. So a team at Kennedy Krieger was given a task by Hugo to identify a biomarker, and they identified C26-lyso-phosphatidylcholine, or C26-lyso-PC, which is as Jerry also showed, something that you can measure in a blood spot, and it's elevated in ALD patients. And then it took another 6 years and the phenomenal work of Elisa Seeger to get the state of New York starting to add ALD to its newborn screening program. And we need to acknowledge Joe Orsini, who I think is on the Zoom, because he made this work, and I know now what a terrible task that is to make this assay work in a lab, and especially at high throughput. So this is the situation I can say this is the situation of the world in 2014. There was only one place where ALD was screened. And this is the situation in 2022. There are now at least 26 states that are screening for ALD. And I think the last one that started was Arkansas in March 2022. But I'm sure Elisa Seeger will correct me if I'm wrong. But it means that, so there's still some gray areas there, but at this moment, 77% of all US newborns are screened for ALD. And that's an incredible amount of numbers. But also in 2013, when New York State started screening, on the other side of the ocean, something happened. Because in the Netherlands, it's the Dutch Health Council that decides which diseases qualify for newborn screening. And Mark Engelen, my colleague, and I, we heard it, that this was ongoing, and we nominated ALD. We got a chance to nominate ALD, and and 2 years later, the Dutch Health Council, they published a recommendation to the Minister of Health to add 40 new conditions to the newborn screening program of the Netherlands, and ALD was one of them. So these are the diseases that are screened for in the Netherlands. So when the newborn screening was expanded with 14 conditions, that didn't start all at once, because you needed this in a phased manner. So every year you add 1 or 2 diseases, because these newborn screening labs, they need to adjust their the diagnostic procedures. And this is really a lot of samples that I need to pass through every day. And you cannot derail this train. This is a slowly moving train, and it has to go on and go on. And you just add another wagon to the train. So these are the this is the Wilson and Younger criteria for newborn screening that the World Health Organization already put out in 1968. And on top of that list is that early diagnosis must be directly beneficial to the neonate, so the newborn. And the Dutch Health Council really takes this first criteria very stringent. And so this is from their report. It says that screening for ALD is only useful in male newborns because the symptoms in women usually arrive at a later age and cannot be treated. Because for the spinal cord disease, there's no treatment. And women do not develop, of course, there are always exceptions, but women do not develop adrenal insufficiency or cerebral ALD. So they do not benefit from early diagnosis. And so according to the criteria of Wilson and Younger, that is true. So therefore, the committee recommends to only screen male newborns for ALD in the newborn screening program. And that is very different, because in the United States, boys and girls are screened for ALD. And as we just heard from Jerry, there's a lot of sense to also screen boys and girls. And when I said this a few years ago here, people were getting angry at me, but I did not make that decision. So, and after 5 or 6 years, I'm on the weighing scale. And I think both arguments are correct. So either screening boys and girls is beneficial, because you will pick up via extended family screening males at risk. But yeah, there's a lot of burden for these young girls. They know that they have a late onset disease. So, but anyway, in the Netherlands, it was decided that only boys needed to be screened. And that is the challenge, because gender-specific screening in the newborn screening program does not exist anywhere on the planet. So we did not have an example, and this required a pilot study, which was referred to the SCAN study, screening for ALD in the Netherlands, or screening op ALD in Nederland. So that's nice. We started with preparing in, I think it was early 2019. And this is a map of the Netherlands. The colors are a little off, but there should be 2 different colors here. And in the Netherlands, because we're such a huge country, we've divided it up in 5 newborn screening regions, indicated with the different colors. And all these regions, they have their own newborn screening lab. And in the pilot, the task was to develop this boy-only algorithm. 2 of the screening regions would participate. So here, the one in purple, for which the newborn screening lab is at the Amsterdam University Medical Center, right next floor of our own lab. So that was very handy. And the other region that participated is the one in orange, because here the reference lab for newborn screening is located. So they always participate. The pilot would last for 1 year. And in 1 year, about 70,000 newborns would be born in these 4 provinces. So, as I said, the task and the challenge that we were faced with was to design, develop, and validate a screening algorithm that includes a test or a tier that identifies males using only their dried blood spots. Jerry also mentioned it. There is a lot. You will pick up other diseases like Zellweger and peroxisomal diseases, but also if you do gender-specific screening, you will identify individuals that have Klinefelter syndrome or Turner syndrome. And the task was not to identify these individuals, or at least not report them, but preferably also not identify them. And we were only given this little 3.2 millimeter or 1/8 of an inch blood spot to do this, and we negotiated, so we got 3 of those, and that's all the material that we had to start with. And a very important test in our algorithm, which I'll show you in the next slide, is what we call the X counter, which was validated by Inge, our research technician sitting over there. Because we had to develop something based on DNA, and what the nice thing is that the X chromosome, there's only one in males and there are two in females. And these are all the autosomes, chromosome 1 to 22, and you got two of those. So in a male, the ratio of an autosome to the X chromosome is 2 to 1, and in a female, it's 1 to 1. And you can test for that because there are little pieces of DNA that are located on the autosomes, and that little piece of DNA is also present on the X chromosome, and you can determine that. And if you do that and you visualize that, then you see these peaks over here in a 2 to 1 ratio in a male and in a 1 to 1 in a female. Of course, this test can go wrong. So we had 3 of those. So we had 3 tests, and we decided if 2 of these are giving the same result, 2 to 1, then the test works. Because you can also say, well, you want 3 out of 3, but if there is a deletion or something wrong at chromosome 2, 3, or 7, and you go after it, then you also identify something that you don't want to identify. So 2 out of 3 was okay. And we used the screening algorithm from the state of New York, which is a 3-tier program, in which tier 1 is done in the newborn screening labs, and then tier 2 is done in a more specialized diagnostic lab, and tier 3 is done in a lab that performs DNA testing. And we placed the X counter here at tier 2. So this is the Dutch algorithm, the 4-tier algorithm. It's the longest algorithm that we have in the newborn screening program. So we start with the baby, and then the initial screening is done in the 2 newborn screening labs that participate. If it's elevated, it goes to the Department of Human Genetics at the Amsterdam University Medical Center for the X counter. If it's 1X, so a male, it goes, the blood spot goes to our laboratory, our diagnostic laboratory, to measure again the C20 glycemic PC. If it's again elevated, we do ABCD1 screening. And if there's a variant, the boy is referred to the pediatric neurologist. In all other cases, we stop screening. So we do not identify other diseases or other conditions. So this is a 4-tier program, and we have to finish this within 35 days, because after 35 days, families will receive notification of the results of the newborn screening. Either it's all okay, so nothing came out of it, or there's referral. And of course, there's a referral that's already done within the 35 days, but you will receive a letter. It's a pilot, so parents need to give informed consent to participate. And while we only screen for boys, the task was to develop and validate this in a real life setting. So we also specifically asked parents of girls if they would like to participate. We started January 1st last year, and the last newborns that were screened were born on the 31st of December. Information is important, so we developed an information brochure, and we developed a website for the information. Okay, so what did we do? In the 1 year that the pilot was running, 72,379 newborns were born in these 4 provinces. 1,171 parents declined participation specifically in the ALD newborn screening, because they could also say, well, we want newborn screening, but we do not want to participate in the ALD newborn screening. So then we looked at the data, and it was about roughly, there were a little bit more parents of girls that decided not to participate, and also 400 parents of boys. And that number of participation is almost equal to the normal participation of parents in newborn screening in the Netherlands, which is very high. It's well over 99%. And in the pilot, it was 98.4%. So these was 71,000 went to tier 1. The newborn screening labs to measure the C20 glycemic PC. And here you see the concentration distribution of all the newborns. And the cutoff was higher or equal to 0.32 micromolar, which is relatively low compared to other states, but we did it specifically because the task was to test our algorithm. So you want a lot of samples. So if we go nationwide, we will probably raise it because there's not really needed to do it solo. So we had all the samples that were above this cutoff were referred to the X counter. So these blood spots were sent to the Department of Human Genetics to count the number of X chromosomes. And these are the results. So we had almost 1-to-1 ratio between boys and girls. So, and then only these samples went to tier 3 to again measure the C26 lyso-PC, but now in a more dedicated method, because you may think, why would you measure it 2 times? The first one is very high throughput, but it's not so sensitive. So there's a lot of false positives. So you need to do it again, but that analysis cost around 7 minutes. So you cannot do that for all newborns. So we had 249 samples that were measured in tier 3. And so before we started, we validated this test. And we had random samples that we were given that we could analyze. And these are the green ones over here. And we had also, with the help of Joe Orsini in New York State, we had some cards from ALD newborns, so we could use to determine the ALD range. And so we set our cutoff here. And this is what we measured in the live screening, which is, well, close to identical to our validation assay. And then there were, and this is the cutoff, and we had no, this is the cutoff, sorry, it's over here, and we had 20 boys that were sent to tier 4, the ABCD1 sequencing, and these are the results. So I call them XY01 to XY20, and 16 out of these 20 had no ABCD1 variants. And 4 boys, they had a variant in the ABCD1 gene. And these were referred to the pediatric neurologist sitting over here, Mark Engler. And so this is the rather complicated but very functional newborn screening layout of the Netherlands. And I will zoom into the part where we are now. So when there's a referral, the medical consultant of the newborn screening program contacts the physician about that there's a positive screening result. And because we could do this the way we wanted to set it up, we did it very patient and family friendly. So what happened is that the consultant would call, well, I think you were called 4 times. You already scheduled, it's nice I can say, you already scheduled an appointment for the family the next day. And the family didn't even know that at that time. And then the medical consultant contacted the family physician, because they know every family physician belonging to every family. And so the family physician probably never heard of ALD. So I got a small leaflet with explanation of what to tell the family. And then the family physician is the person who contacts the family. And we never do that on a Friday. We've heard stories that on Friday afternoon at 5 o'clock, people got a notification about the screening result. There's no immediate rush for ALD, so we don't have to do that. So in general, this was, I think, was done on a Tuesday. And then on a Wednesday, the family had already had an appointment with Mark. So to limit this time of complete uncertainty and browsing the internet. So, and then the family visits the, one more minute. So then we go in this follow-up program, which Mark will talk about in the guidelines. And I can skip this. Oh yeah, one more thing. So we also investigated other stuff. So we looked at the effect of gestational age of sampling, and birth weight on the C26 lyso-PC, because that was something not known. What do you do with preterms? So this is so we had the information from 70,000 babies, and these are the males and females. So the longer the gestational age, the more birth weight, the higher birth weight. This is not really new. So this is birth weight against C20 lyso-PC. So there's no effect. It's equal. The mean is equal, and this is gestational age. So there's no effect of gestational age on C20 lyso-PC. So the conclusion here is that we do not have to take into account gestational age, gender, and birth weight for measuring C20 lyso-PC. And then I can skip this. So and now what? So now we wrote a final report. This will be evaluated by the Minister of Health, and then there will be a go no-go decision. And we hope that when politics are moving, we start screening nationwide next year. But I'm afraid that it will also be 2024. And this is everybody who participated in this large project. And thank you.
Skip questions. We haven't started the session again, but the next speaker is you, right? Or is Mark going to start first? Both of you.
I was taking two sessions.
Oh, okay, okay. So, well,
I had everything.
well,
Okay. No, we do.
So yeah. So
you.
who's gonna start? You or him?
I'm done.
Oh, you're done.
Yep.
So you are already into. Okay. Okay. Good. All right. Well, then it's not too bad. All right. I mean, you just made it because it's actually 45 already. So it's like.
Right. We're running.
Yeah. Right. Okay. Good. So then let's switch gears. So Mark Engel, Dr. Engel is a pediatric neurologist from the same place as Dr. Kemp, and he put together an international group of experts to come up with standard of care guidelines, and this has been a big effort. So go ahead.
Right. Thank you. I might need some technical support because no, it's working. Well, thank you very much, Ali, for the introduction. Good morning, everybody. This. Oh, sorry, force of habit. But this is not my work. This is the work of actually many people present here. And all the contributors will be listed at the end because it's a long list. I couldn't fit it on the title page. So what I will speak on is some international recommendations that we have put together to try to standardize the care for people with ALD of all ages. And we tried to fill in our knowledge gaps, of which there are unfortunately many, with a consensus-based approach to find a rational follow-up protocol. Yeah. Yeah. All right. So why do we need guidelines in the first place? Oh, sorry. Somehow the system thinks I have two screens attached. Sorry, Ali, I'll talk quickly to make up time. As soon as this. Yeah, probably there, right? Yep. Yeah. I think that should do the trick. No. Sometimes there's a button to switch screens sometimes.
Yeah.
But it doesn't pop up. Maybe here? Let's see. No. No.
Can you just do
Oh yeah, it's no, because it's in full screen mode, I guess. Oh no, the cursor was on the big screen.
Yeah.
Yeah. Still is. There it is. So
Is one thing mirror?
oh, here, this is it. Match screen.
Now do now.
No, let's try to present on that. Oh, stupid thing.
Just do.
Yeah.
Just do this.
Okay, I'll just
Okay.
yeah,
You
I'll
can
just
keep it.
maximize the screen and
There you go. And
yeah.
the arrow keep going.
Okay, so sorry about that. So why do we need these guidelines anyway? Well, basically, we find that it brings clarity to patients because they can look up what kind of care they should expect. It's also something that gives some kind of a framework for doctors, especially doctors who are not experts in these rare diseases. They can look up what the recommended diagnostic procedures are. And also that kind of depends in the country where you live, but sometimes in some places when it's difficult to get reimbursement for care, it helps if you can show your insurance company, this is the minimal level of care I should receive. So we thought that it would be beneficial to all parties in the healthcare system to have some kind of standardization. And there are many clinical questions concerning the optimal management for ALD. And especially now in this area of newborn screening, as you've heard, we're learning new things. We're seeing patients in different disease stages. So there's lots of gaps to fill. And what we tried to do was to reach consensus on what is currently the best approach to the diagnosis, management, and to get to optimal outcomes. So before we go into detail, this slide you've just seen, but sometimes repetition is not a bad thing. ALD is a very complex disorder. You could say it's an entire spectrum, which is characterized by adrenal failure, by leukodystrophy, and by spinal cord disease in different combinations, and with an enormous variation between patients. So male patients almost invariably get in adrenal failure. We estimate the lifetime prevalence to be about 85%. And adrenal failure is something that is clinically difficult to detect because symptoms are very aspecific. So that is something that you rather pick up in an early stage so you can start hormone suppletion and prevent unpleasant complications. The leukodystrophy is also something that only affects male patients. It's unpredictable, and we estimate the lifetime prevalence to be about 50–60%, often in early childhood. And like was mentioned already, that is also something you want to pick up in an early stage, preferably pre-symptomatic with only radiological abnormalities, because then the transplanters can treat these patients and provide a much better prognosis. And then lastly, the spinal cord disease, which is basically the core symptom pattern of both male and female patients that occurs in adulthood, sometimes in late adulthood. But this is something that will eventually affect all male patients and virtually all female patients. And unfortunately, for this aspect of the disease, we have no way to prevent it or slow it down at this time. But then again, Wolfgang will present on some hopeful developments for the future. So if we put it all together, the ALD, everybody is born asymptomatic with no problem at all. And during life, in adulthood, a myelopathy develops in male and female patients, and male patients often develop adrenal insufficiency and sometimes the leukodystrophy. So in the management, we see that there is much variation. Basically, the type of care you receive is highly dependent on where you live and what doctors you meet. And that is partly because there's little hard evidence concerning many procedures. So there's a lot of, that is in the absence of evidence, you always see a lot of variation appear. And there's also, of course, differences between the healthcare systems that determine how easily you have access to specific care. And I would like to highlight some variations that we are aware of in both in the ways to establish a diagnosis and what kind of follow-up and treatments are administered. So one change that occurs the last 5 to 10 years is it used to be the diagnosis was only considered if there were specific symptoms, and then people would do specific confirmatory testing. So everybody who came to a specialist had a high a priori probability of having ALD, and that completely changed, because nowadays, if you come into a doctor's office with unexplained symptoms, you will probably get whole exome sequencing at some point. And that is a great technology, but unfortunately, you pick up a lot of accidental findings. So nowadays, we often get kids who are tested, for instance, for intellectual disability, and then they also have an ABCD1 variant. And the ABCD1 variant will have absolutely no relation to the intellectual impairment, but then you're faced with somebody who had a very low a priori chance of having ALD, and then you have to confirm the diagnosis. Same thing with newborn screening. That's also, you get asymptomatic patients with no family history. So then if you find a variant, it's kind of a challenge to see if that is really a pathogenic variant. And that is not very trivial, as we will see. And there's major differences in how people approach that. And it has major consequences. If you tell somebody they have ALD, that will affect their life in a major way. So you have to be certain. Another thing that is very different is the MRI follow-up. And I can, so how often do you do the MRI follow-up? Do you do gadolinium every single time, or don't you? The adrenal function, when do you start monitoring? How often do you do that? And so to try to come to a more uniform plan, we contacted people all over the world who have experience with management ALD, mostly from Europe and the United States. And we started with generating these questions. For instance, how do you do MRI follow-up? What confirms the diagnosis of ALD? And we did an extensive literature search as a basis. But that literature search, that's as expected, that didn't yield any solid evidence to answer most of these questions. So then you have to rely on expert opinion. And it's always difficult to get those experts to agree on anything. But that is a common problem. So people developed a system that they call the Delphi procedure. And that is kind of a systematic way to guide your discussions and to end up with some kind of consensus. And consensus does not have to be unanimous, as we will see, but at least the majority has to agree. And it takes, that's a three-step process. So you start with sending out questionnaires, and then you process the first questionnaire, then you send out the second one, and people can read the comments of the others and revise their opinion. And then the most difficult statements are discussed in a live consensus meeting. Well, it was a Corona consensus meeting, so it was not in real life, but we made do. So how is consensus defined? Well, people score the statements that are provided with the numeric value, and they either give it a low score, completely disagree, or a high score. And if 80% reaches scores between 1 and 3, or perhaps 7 or 9, consensus is reached, and either the statement is rejected or approved. So progress so far, it sounds simple. It should be simple, but it took many years. So we collected a large group of people, clinicians, laboratory specialists, radiologists, and eventually 28 experts from 12 institutions in 6 countries participated. And we went through the entire procedure, and yeah, currently we're hoping to get it published somewhere this year. It's a long process, but we're getting there. And I would like to provide you with some highlights in the guideline. I'm not sure this is readable, but this is something that we had actually very long discussions about, because it seems simple, right? ALD. You got a genetic test, shouldn't be difficult to make the diagnosis. But like we said, because of the whole genome sequencing and the newborn screening, we are now often faced with, well, people with a variant, but no symptoms and no family history. And then it can be challenging to say, this is really a disease-causing variant, because sometimes you would have to wait 30 or 40 years to be sure. And we created an algorithm to include functional testing in fibroblast and try to standardize that to give people some support in going through this process. yeah, and we hope that this will lead to a more uniform definition of when to make the diagnosis. But there are still gaps in this that we will need to fill in the coming years. So about follow-up, what everybody agreed on is that there should be screening for the cerebral ALD in male patients. And we came to some kind of consensus on frequency and also that only male patients should be screened. Yeah, this was a hot topic because I think that we used to give gadolinium to all our patients at every checkup. But if you start screening between 2 and 3 years, and then twice a year and later once a year, that's a lot of gadolinium scans over a lifespan. And there are some hints now that it probably accumulates. So what we discussed is that it's probably okay not to do gadolinium scans every time, and we describe some ways to make that a safe procedure. Yeah, then there's the adrenal screening. That is actually something that also changed because of newborn screening. Because a couple of years ago, I would say, oh no, that'll never happen before the age of 3. Well, another thing in which I was wrong, because now it's clear that you have to start much sooner. So we do some recommendations for that. And what unfortunately did not reach consensus, but that might be something for the future. We think that if you're, well, I wouldn't say old because I'm pushing 45 myself, but when you're later in life, if you have not developed adrenal failure, maybe you can stop testing because there's a small group of patients who will never get it. But on that, we could not reach consensus yet. Yeah, and as for treatment, made some recommendations on the indications for hematopoietic cell transplant and the gene therapy, but that's because it took so much time to get it published, that statement could be taken out because in Europe, unfortunately, that treatment is not available anymore, but our American colleagues still have that option, fortunately. Yeah, and also an interesting point was the discussions on the Roy Andrews oil, and on that I have to say there is consensus as defined on the previous slides, but in the paper we described the discussion because it was not unanimous by far. So, and one maybe not so spectacular thing, but we also try to stop calling women with ALD carriers because we think that they have ALD with different symptoms from the male patients, but the term carrier still does some damage because it suggests that you never get symptoms. That can lead to all kinds of inappropriate tests and procedures. So, sorry, it was kind of a boring, long ramble, but we do hope that to structurally put this in a paper that we can make some steps forward in offering uniform and good quality of care to everybody with ALD. Well, I didn't start with a disclosure slide, but we got financial support from several biotech companies, Bluebird Bio from the gene therapy, of course, Swan Bio, Minorix, to hire the services of Adelphi to help us through this complicated process, and they organized a lot of the meetings. But I want to state that the companies had no influence on, they had no voting rights on the statements. So we do think they're independent in that way. So we hope that this project will lead to better care worldwide, and that it will also facilitate the implementation of new treatments when they become available. And this is the list of collaborators I promised, very long, many people present here, and all the institutions they are from. Yeah, and I hope that they will be available later this year. Made up some time.
So I think we have a session now on bone marrow transplant with 3 other speakers. Should we just go through those and then we have a 15-minute discussion session? So I think that it's better to probably do it that way. So I don't know which of you 3. Okay, so Dr. Troy Lund is from University of Minnesota, and he's going to get started. Oh.
Right, thanks. All right, thank you. So this is just a basic introduction to transplant and cerebral disease in less than 10 minutes. Since Paul and Wolfgang are going to talk about the new stuff, and I just typically talk about the historic stuff. So I'll try to make it brief. So cerebral disease is characterized by the enemy gadolinium enhancement, as shown in the right pictures. The little ring here, this is the gadolinium we're always talking about. And then another part of the disease is what we call this T2 demyelination signal, which is shown here in white, and that's a different brain. So that's the injury as a result of the inflammation. Staging patients. We always talk about the neurologic function score. It is a table of dysfunction. Points are awarded for having a symptom or sign neurologically, and you can see the points here. Having walking difficulties is a point or 2. Having field cuts is a point. Most of us should be at a 0, but as symptoms progress, you end up having more and more points. And so we use this in staging our patients. And then the LESS score, lots of questions always about LESS scores from families and what they are and what they mean. So developed in 1994 by Dan Less and others. It's a score based on the amount of damage seen on MRIs by structure, not by area. So you can have a huge amount of area involved, but a score of 1. So here's some examples. On the far right, a score of 1. In that little part of the midbrain here, there's a couple of lesions bilaterally. Here's another score in the splenium. This is a 1.5. It's unilateral. Here's a score of 3 in a young man. And here's a score of a 7. Why is he a 7? Because it looks the same as a 3. Well, if you look at his midbrain region, he's got more points because of these structures. So again, it's number of neuroanatomic structures, not area. So it's a point of a lot of confusion and discussion. So that's part of our staging as well. So then I usually talk about the terms of transplant. So transplant is not always transplant. The terms we use are hematopoietic stem cell transplant or hematopoietic cell transplant. That's the one I use because it's not always just stem cells we're infusing. Sometimes it's called bone marrow transplant or stem cell transplant or umbilical cord blood transplant or gene therapy. They are all transplants, and they are pretty much all identical in the kind of chemotherapy you're receiving, actually, though the stem cell product is different. We can do autologous gene therapy types of transplants, or we can do allogeneic transplants. Allogeneic is when you use a donor that's not yourself. So you can have a related donor, that's usually a brother or sister. You can have an unrelated donor, that's usually somebody else out in the world that matches you. You can be so-called matched based on HLA proteins, or you can be mismatched. And depending on who's doing the matching, we can talk about the levels of matching and what they look like, but it's usually 6 proteins, 8 proteins, or 10 proteins. And then we talk about the source of stem cells. We mentioned it could be umbilical cord blood. It could also be peripheral blood. These are usually GCSF mobilized peripheral blood stem cells, and it can also be marrow. And then there's a special type of transplant called a syngeneic transplant, which is twin to twin, which almost never occurs these days, once in a while. So what does the workup look like for somebody with cerebral disease, cerebral ALD? Usually we're establishing LESS scores. We're usually establishing neurologic function scores. We're looking at the overall health of the patient. We discuss risks and benefits. So again, more details on the workup for the child to see if they're suitable for transplant. We look at their disease status, just as I mentioned. Sometimes we collect blood and sometimes spinal fluid. We look at total protein and other biomarkers to help us predict course. We look at HLA matching. We look at donor availability. That last part is becoming more and more important because of COVID. Donors are becoming less available, unfortunately. Then we assess the child's heart, lungs. We look at past infections. We look at their age, and there are many other risk factors depending on the child and the age, especially if it's an adult. And you get into all sorts of different risk factors. So after the workup, we place a central line to allow delivery of chemo, draw labs, give the transplant. There are 6 to 8 days, let's just call it a week of chemo delivered in the hospital. Transplant day is always called day 0, and then everything beyond that is day plus whatever. Usually recovery is in the hospital. It's 14 to 28 days for most of these transplants, and you experience the side effects in that point in time, usually the hair loss, the mucositis, fevers, nausea, etc. At this point in time, we're watching out for infections because you don't have an immune system. So it's kind of the most dangerous time. But then once you engraft, your neutrophils come back, you can be discharged from the hospital, except you don't get to go very far. You have to come to clinic every day once you're out of the hospital, and then every other day if you're doing well, then every 3rd day, then every 4th day, and you kind of get the idea. And usually patients can go back to their home, wherever they're from, their home institution, home city, by about 60 or 100 days after transplant, because they're usually doing pretty well by then. They return to us every 6 months for the next 3 visits, and then yearly thereafter. So then there's some pieces of data. These are Kaplan-Meier curves or survival analyses. So 100% is on the right side. The ticks represent an event, and a step down represents a death. And so this is our own institution data. This is looking at low-risk children using related donors. So that's a sibling. We have 100% survival. All those patients do exceptionally well. I always call this the gold standard of transplant because this is what we measure everything else against. If you have an unrelated donor, there are complications. It could be graft versus host disease, other infections, other transplant complications, and so their survival is a little lower. Again, catching the disease early, this is survival by less score. So if your less score is less than 10, you can see on the black line that survival is fantastic. It's 90% or higher. But for advanced kids, when they're greater or equal to 10, survival is definitely lower at 60%. And these days, if the scoring is near 14, 15, 16, or 17, we really don't put transplant out there as an option because those kids historically have done just really terrible with very little survival. And then I wanted to throw in a slide on neurologic function score. That can also separate patients on survival. If you are a 0, that means no symptoms. You do exceptionally well. Survival can be 90% or higher. If you have some symptoms, it's a little lower. And if you have a lot of symptoms, so more than 1 point, it's lower statistically still. Some of these curves have changed over time. This is back probably now 10 years ago. Or 11 years ago, and some of these curves have actually improved because their preparative regimens are less severe, but I think more or less the data still stands in its pattern. And then the goal, as I remind people, is, again, this is the child with a gadolinium-enhancing lesion shown here, 28 days after transplant. All that gadolinium has disappeared, and so the active cerebral disease process has been extinguished. And that's the goal of going through transplant. Unfortunately, any of the demyelination that has occurred is what I call the CLD injury that remains lifelong. So again, important to catch the disease as early as possible. We can do that now thanks to newborn screening and have the best outcomes. So I'm going to stop there in 9 minutes and give it to Paul Archard.
everybody.
Thanks, Troy. So get this going here. That working? Great. Okay. So I appreciate the opportunity to talk with people this morning. So Troy's obviously given the background on bone marrow transplant. There's been a lot of discussion earlier about what ALD is, so I'm not going to focus on that. I'm going to just have a few slides here. But I think before we get started, the concept of using transplant for ALD is kind of an unusual one, frankly. And so historically, as I understand this, back in the 80s, people started using transplant for lysosomal diseases, including lysosomal leukodystrophies, Krabbe and MLD. And it looked like there was potentially some benefit there, albeit not what we would like. So the idea was, and Hugo Moser got started with this, and Bill Krivet, who was at our institution, was quite interested in this too. So I think at that point, people recognized it was a peroxisomal disorder, but they still thought it was an enzyme deficiency. And so they thought, well, lysosomal, peroxisomal, maybe it doesn't matter. We'll try allogeneic transplant for ALD. And, you know, the first couple of kids that were done were quite advanced and did really poorly. And it was kind of on the cusp of whether or not this really made sense to do. And Patrick Oberg, who was in Paris, transplanted a kid very early, and that kid did well. So transplant became understood as a mechanism to treat these patients. But then it became clear that the gene product is not an enzyme that can free float from one cell to another, because that's a concept with using transplant for some of these other diseases. You put in blood stem cells that can differentiate into other blood cells, and those cells are making enzyme, they will give enzyme to the other cells. So that doesn't happen with ALD, because the gene product is localized in the membrane of the peroxisome, and it doesn't free float and get to the other cells like it does for the lysosomal disorder. So we still don't know how transplant works. I'll say, you know, at the beginning, which is kind of an important thing to understand. I mean, obviously there's been hundreds of kids have been transplanted. We have a pretty good idea of what works and what doesn't, and what patients benefit and what don't. But fundamentally, we don't really understand how transplant works. So the caveat then to say, well, why do we need gene therapy is maybe a next question. So as Troy was showing, so if you have patients that are early in the course of the disease and they have well-matched donors, they tend to do pretty well. So, you know, again, why should we think about doing gene therapy? Well, we still lose globally 10%, 15% of the kids die going for transplant. And it's complex because there's two immune systems. You have to knock out the immune system of the person getting transplanted so the new cells will take and grow. And so that requires intensive chemotherapy. And then the new immune system that's coming in can react to the patient that's been transplanted, and that can cause graft versus host disease and a whole host of other issues. And so it requires that the patients be on immune suppressive therapy for a period of 6 months, if not longer, to help keep those problems from happening. And then if things are going well, we wean them off. But transplant's a very difficult process to go through, and anything that can make that better and less hard on the kids and the families would potentially be important. So that was really kind of the rationale for discussing gene therapy. So the process with gene therapy is a bit different than what we do with allogeneic transplants. So I'm going to come over here actually. So the lentiviral based approach is what we're going to talk about here first, because that's really what's been developed. Requires that you get blood stem cells from the kids. So to do that, there's a couple of medicines that we give the kids. It releases the blood stem cells that are ordinarily just in the bone marrow, and they go into the blood, so you can pull them out of the blood with, yeah, we need a pretty large IV or a catheter place to be able to do that. So there's about 5 days worth of medicine. So we give the kids to release the cells. Then they go on one of these machines called an apheresis machine. The blood comes out, passes through the machine. The machine takes out the cells that we want. The rest of the blood goes back into the kid. And then that's a 4 or 6 hour procedure. Usually we can get enough stem cells with one go around to do that, but sometimes we have to do it on 2 different days. The cells are then sent to the manufacturing facility, and then there's a virus there that has the ABCD1 gene in it. And this virus is based on HIV, so it's based on the AIDS virus. So essentially, and that AIDS virus is very good at getting into cells, but you cut the guts out of it, you cut the HIV specific pieces out of that virus and replace it with what we want, which is the ABCD1 gene. So this process of essentially infecting the cells is what we call transduction. So that happens outside the body, it happens in the laboratory, and then the cells are frozen. And then there's a bunch of tests that they do to make sure that the process went okay and whatnot. So that takes about a month to actually get the go ahead. Once we have that, then the kids will come back to us, and they still need chemotherapy. There was 2 trials that were done, 2 Bluebird trials. One was with busulfan and cyclophosphamide, which is the chemotherapy that we've been using for 30 years, essentially, to help treat patients for transplant. And then the more recent protocol used a bit less chemotherapy, so it's busulfan and fludarabine, but it's still quite intensive chemotherapy, similar to what we would use if they were getting somebody else's cells. So that has to be done in the hospital. The cells go in, and cells just show up in a little bag, and they go in about 20 minutes. I mean, that's a very easy process generally. And then the kids have to recover afterwards. So the idea is that, and again, it's not enzyme here, but the idea is that the cells that now are manufactured and are making ABCD1, because we think that's important. Again, understanding we don't really have a full concept of how transplant works, but those cells we think need to get into the brain and set up shop there, and then that can help stop progression of the disease. So there's so if you're going to say, try to figure out if gene therapy works as well as transplant, survival, of course, is one thing that's straightforward, but Troy was alluding to the MRI score. So this is the LESS scores again. So these are areas of the brain that are affected. And this is some of the data that was generated with the gene therapy study. So most of the kids that were on these studies had relatively small amounts of disease. So the median was a 2, which is quite low. But it just gives you a sense of how the MRI scores have changed over a period of years with gene therapy. So most of the kids are fairly stable in terms of their scores. There are a few patients that progressed significantly. In that first study, the 102 study, there were 2 kids that progressed enough that they came off study and got an allo transplant. One of those kids survived, and one actually died going through the allo transplant. And this patient progressed so quickly that he wasn't offered transplant, and that patient died of his disease. And Troy also was talking about this. So this is the neurologic functional score. And so this is a functional outcome, as opposed to the other one was just an MRI-based outcome. And, most of the kids, almost all of them, I think it was one kid that wasn't, but almost all the kids were asymptomatic when they went on the gene therapy study. So they didn't have any vision problems. They didn't have any hearing problems, seizures, or any of those issues. And most of them continued not to have those issues, which is clearly important. This is that patient we talked about before. But one of the things that's come up recently, and it's kind of thrown a wrench into all this. And I think this is, I know there's a lot of interest in this, and it probably needs to get discussed. There are 3 cases now, excuse me, 3 cases now that are developed with myelodysplasia, or MDS. So myelodysplasia is a pre-leukemic situation where the blood counts tend to be low, the cells look abnormal, and it looks like there's one particular cell that was transduced by that virus that is now outgrowing all the other cells. So that we call that clonal expansion. So these things will progress to a full leukemia and be lethal. So this is a major concern on the protocols. There's 3 kids now out of 67, so it's only 4%, but obviously there's a lot of kids we're still following. All 3 of the patients, the best treatment for myelodysplasia is allotransplant. So all these kids went on and have gotten allotransplants. They're all doing okay, best I can tell. But they're all early. They're all within the last 6 or 9 months, I think. So hard to tell whether there'll be more cases. There's kids that are being watched still. And it's hard to know if these 3 boys are going to do okay. But this obviously was a concern for, well, for everyone. I think maybe most people know. So 2 weeks ago yesterday, Bluebird presented their data in terms of outcomes and safety related issues to the FDA. There was an FDA advisory committee. It's a full day meeting, 2 weeks ago yesterday. And all these things were discussed in terms of comparisons to allotransplant and how much difference this is going to make. And there was a vote at the end of the day, basically, to say, are we going to recommend that this move forward towards licensing? Because this is all experimental therapy at this point. And the vote was unanimous to move forward towards a licensed product. So it seems likely, it's not a done deal yet, but it seems likely that this will eventually get a license. Whether that's going to mean 6 months or longer, it's not clear to me. So right now, the trials have finished. There are no spots to enroll additional kids. There, we can get one-offs where we can ask the company to help us with a particular kid, but that's, you have to present that to the FDA and get approval and or whatnot. So, it's not totally unavailable, but it's very difficult to treat kids with gene therapy right now. But, maybe in 6 months or a year, it will be FDA approved and we won't have to go through those processes anymore. So I'm going to stop there, actually. And then, great.
So, hello. Well, I'm an adult neurologist. So the situation in adulthood seems to be completely different a little bit. So what I experienced over many years is that I lost so many people, so many very nice people with cerebral ALD in adulthood. And I'm currently working on this data, and recognized there were over 60 people that I lost over the years with cerebral ALD. And this, at some point, it was such a terrible situation that they was asking me, together with some other colleagues, what can we do in this situation? What can we learn from Paul and Troy, and from Bill Cribbett and from Hugo Moser, who tried to do the stem cell therapy in children with great success? Of course, we know that the situation in children is completely different because they were transplanted when they have no symptoms or very minor symptoms. And in our adult patients, they had symptoms maybe for 15 years already. AMN and things like that, their walking problems and all other kinds of symptoms. When they started at a certain point with cerebral ALD, which changes completely prognosis, similar to what we know from childhood cerebral ALD, to 2 to 3 years until they pass away. So we had some early experience from, especially from the US, anecdotal transplants in adulthood cerebral ALD was no good results. But all of these patients were transplanted in very late stage of the disease. So we thought that learning from the children experience, why don't we treat these patients earlier, a little bit earlier? So we started to treat a couple of years ago adulthood cerebral ALD patients when they first get their MRI changes, so at a very early stage. And then we gathered some experience a couple of years ago together with other centers. In the sake of time, I skipped some of the slides. So this is a summary of our first group or cohort of adult cerebral patients that we gathered together a couple of years ago. 8 of these patients, or 9 of these patients, were from our center. There were 4 patients from Paris, and there's 1 patient from the UK, from Sheffield. And we come up with this curve here. This is a Kaplan-Meier curve, which gives you an impression what is the best guess, how is the outcome of these patients over time. In this case, the outcome of survival. Who will survive after this treatment over time? These are months. And what you can see here, we recognized that from 100%, about 60% survived long-term. This was the first idea that it is possible at all to survive with this disease. We didn't know that before because 95% or more than 95% of patients in adulthood with cerebral involvement would die. So we had, with this treatment, for the first time, we could show that it is possible to survive using this treatment. Yeah, so we also recognized that this treatment is not as toxic as we thought previously, because we know it's very dangerous. And what you can see here, that some of the patients died in the early phases, in the first months after treatment. So this is always a critical situation. When you start treatment and in the first year, you have all these complications from the treatment itself. And this gives you a high risk with this therapy. But when you survive the first year, you can see the survival is long-term, is good. But what is survival? Yeah. What about long-term disability? It's not, maybe sometimes not important just to look at survival. Yeah. But how do people survive? What is the disability on the long term? And we didn't know at that point what are the parameters that would give us an idea what is the outcome. So are there parameters? For example, is there is somebody who has already cognitive deficits when he starts his transplantation? Has he a worse outcome than those who don't have the cognitive deficits? Are the ones who are in the wheelchair already different before when we start the treatment in terms of the benefit and the outcome than those who are still able to walk independently? So these are all questions we didn't know at that point, but it's very, we are optimistic. We have, for the first time, we could see that there is a chance to survive, at least. Yeah. Oh, sorry. I'm not able to handle this technique here. So then we worked further, and in the meantime, we transplanted 23 patients. And these are results from 19 patients where we have long-term outcome. And this is only our place. It's not an international corporation. It's only Leipzig. Okay. What we see in the meantime is that the survival rates are getting better and better with new techniques, with new medicines. And in the meantime, I would say we can reach a survival for the cerebral ALD situation of 70 and 80%, which is close to that what happens in the children. Even though all of these adults do have clinical symptoms already when they started with the transplantation. So this is one important point. But we also could see that the ones who have very minor neurological symptoms, let's say they're without any cognitive deficits, they're still able to work, able to do everyday life situations, no problems at all, and they're still able to walk independently without any walking stick or so, that those people do have really a good chance for a beneficial outcome with the transplantation. What does it mean? That means that we really need to closely follow up our patients and to detect the cerebral involvement as early as possible, like we do in the children. And we do that in this situation, and we catch the people in the very early stage of the cerebral disease. We now can really recommend and are able to do this treatment in adults as well. It's the same thing like in the children. So I think this is good news, but we all have to, to have these investigations on a regular basis, which is in the guidelines also mentioned. We have this in the guidelines, so we need to see the patients every year at least, to need to have an MRI every year, yes. So this I wanted to say you that's not hopeless. We can really we had a good chance for treatment, but we need to catch the situation of the cerebral involvement as early as possible. This is my message. Thank you very much.
Questions, and then there's going to be a 15-minute break, and we have 3 more presentations after that break. So Who is within the window where cerebral disease may present itself? Can the urgency of having the brain assessed be quantified in the guidelines? In some health systems, assessment of urgency can be variable, resulting in significant delays. It will be helpful for patients to have something concrete to point to join advocating for themselves. I think that's a good point. So this is a question coming from Ms. Finn with the idea that what is the urgency once you have that diagnosis? So who wants to comment on that? Maybe one of the transplant folks. Okay, hold on.
Right. Sure, I'll comment first. Yeah, there's different levels of urgency. There's emergency room urgency, which is 24 hours, and some people have that feeling that that's what they need. It's not exactly emergency urgency, but there is some rapidity to getting the MRI and staging. So how do I break it apart? Well, you don't need to be in 2 days, but some healthcare systems force you to wait months. And I'm not making it up, 4 to 6 months to get an MRI. That is way too long because you can significantly advance your cerebral disease. And so that's kind of how I break it apart. So what's reasonable? Reasonable for me is probably 2 to 4 weeks to have that MRI scheduled. I know all families want it the next day, but I usually say 2 to 4 weeks is a very reasonable time frame. But again, not all healthcare systems recognize that. And if anyone has a different answer, that'd be fine too.
Yeah, I might just comment too, and maybe there's Mark or Florian or somebody wants to, or Jerry, if he's still on, wants to weigh in on this as well. But some of this depends, I think, a little bit on how advanced your disease is. So the kids that have the less scores of 1 or so seem to be more slowly in terms of progression. When you get up to a score of 6 or 8, and sometimes those kids progress very significantly over a period of a couple of months. So it may depend a bit on at what stage your disease is. And I might just comment here quickly too. So another set of issues here is, so we've been talking about this less score, which is how extensive your disease is, but there's actually a lot of variability in how those things are read. And we've been talking about trying to figure out if there's some way to be able to offer like a second opinion on what the less scores are, because if you're in an area where somebody's not very familiar with the scoring system, you can get wide discrepancies in terms of how the less is read. And if it's read as a 12 and somebody says you shouldn't go to transplant, and then somebody who's experienced with it reads it and says it's actually a 7, it's a totally different situation. So those things end up being problematic, I think, too. So, but again, I'm no neuroradiologist, certainly, or radiologist for that matter.
I agree. I think one more comment along that line would be that as we are doing more newborn screening for these newly developing lesions very early on in the disease, we are detecting these kids as they have these tiny little brain lesions now in the brain. And I think in those scenarios, it's probably very reasonable to have a 4 to 6 months window even, right? I mean, that's sort of what we're telling our families, somewhere along that line. So that definitely, because that's, I think, the scenario we're going to be facing more and more I may probably have even more than 6 months. I know Florian and Eric Malik, you know, we probably have even a year to go in there, perhaps even. Depends, it's of course variable there, but when you have these tiny little lesions, I think that's a very different scenario than somebody who comes up with a score that's close to 10, and yeah, then you have to rush it, of course. So anybody else wants to comment on that? I don't want to be the one. Yeah. 2 questions. You want to do her first?
I think I just wanted to try to clarify the posture. A child is diagnosed with ALD but has not had an MRI and is in that window. If you would recommend.
Yeah, I mean, I think that's what Troy was saying was the earlier the better, but obviously, you know, that's
well, I think then that leads to the problems with our system, because I would hope that with a newborn screening, when you have babies that are identified, they're going to be put into the system immediately, and they are beginning a lifetime of seeing professionals who will then refer them on. I mean, I think a lot of people have had experiences with seeing doctors for years who didn't know anything at all about leukodystrophy and didn't know that they didn't know about leukodystrophy. So they just were treating whatever they thought they were looking at. But now I hope you will have pediatricians all across the country and the world eventually seeing these children with these positive results and saying, whoa, we need to get up to speed on this. And we need to watch them and see, even beginning with the adrenal insufficiency, and to watch for when their adrenal is sufficient as children, because I think I've heard a lot of stories of people who've died from an adrenal crisis because they didn't even know they had that. And so I hope that our system's going to catch up with that. Anyone for advocacy?
Yeah, I think the key issue is to get to an expert center as soon as you have a diagnosis. There is 7,000 rare diseases. We can't expect general pediatricians to know all about them, right? But I mean, recognizing that, okay, this diagnosis triggers referral to this person. And then once they're in that system, things will go well. But then there's an access issue, because there isn't enough experts within each country, and within this country, even within each state. And we have states that are newborn screening, that have active newborn screening, that are still adapting to gaining that expertise, right? So, and then we have states that have experts but don't have newborn screening, like
Okay, I've had several questions from doctors regarding palliative care and treatment for boys who are too advanced for bone marrow transplant. What do you recommend? What's the consensus for families who want to give something?
Yeah, so there are no easy answers. I think the one thing we want to be careful about is saying that one size fits all. I think these have to be judged on an individual basis. What are the more urgent needs? What are the symptoms? What is the level of comfort or discomfort? We are all, I think, hoping that we are going to be bringing forward more experimental treatments to advance cerebral ALD, but just because we don't have experimental treatments at hand doesn't mean we shouldn't fully recognize the power of symptomatic management and care. And I think there's huge value in attending to those daily needs and understanding what is the level of pain, spasticity, bowel bladder symptoms, what our caregiver needs themselves, how much support do they have, how do we prevent caregiver burnout, are there seizures, can those be controlled? there are many aspects that I think we as physicians and nurses, physiatrists, and many other disciplines can help improve. And I think families also have a lot to share about that with us and with each other. And I think there's a lot of room here for progress.
I couldn't agree more. That there's a lot of things that you can still do, right? And so my biggest challenge in the clinic, personally, to be honest, is that I introduce palliative care idea to them, and there is a lot of resistance from many people. They don't want to hear that, and I think that there's sort of this misjudgment that, oh, palliative care means I don't want to take care of my child. No, that's exactly the opposite. It's the whole point here is to help make the best out of that remaining life. And again, there is a lot that can be done to provide comfort, to provide, avoid pain, avoid things that can be done. And it's just, it needs to be a sort of a spectrum of conversations, not just a yes and no kind of an approach. Does anybody else want to say something there?
Really quickly. So it's a problem when we get patients that are referred to us that have somewhat advanced disease. If their LES score is 12, they may have a little peripheral vision loss. They may have a hard time understanding complex questions, but they're pretty functional. They may be out, playing soccer. And then we have to tell the family you're too advanced to get a good outcome with transplant. And so what we've seen historically is kids that are on the cusp like that, the transplant makes them worse, and it does it quite abruptly. Like over the next couple of months, these kids tend to lose a lot of ground. So I just got an email from Singapore earlier about a kid that's like this. But if you, even though they're quite functional coming in, if they leave and they're blind and they're in a wheelchair and they're incontinent and they can't understand what you're saying to them, then obviously that's not an outcome that we are looking for. So, are there agents that might help us stabilize these kids as they go through transplant, and you can expand the number of patients you could potentially treat would be great, but we haven't found anything like that. So
yeah, just practically and medically speaking, I completely agree with the supportive care and palliative care, but if parents really want to try something, I've spent a lot of time coming up with different immunotherapies. As an oncologist, we have an access to a wide array of drugs and are familiar with them. So sometimes we can get access to these drugs for a non-FDA approved indication. And so I've offered that to families because they're very dissatisfied with doing nothing or just doing palliative care for all these reasons. And we've certainly made a lot of attempts, probably over the last 2 decades, at trying some of these agents. I can't say we actually have any major successes, and I fully disclose all the agents and the outcomes of everybody, but we certainly have learned a lot from employing different avenues, and maybe we've modified natural history a little bit, but that's one of my more practical approaches. But there's definitely no consensus on it. It's something that each physician could, can try to make up or try if they want to.
Process, you still progress quite rapidly.
Right, for transplant? Yeah, it's a fantastic question. So, somewhere, there's no clear number because everyone wants a number. So, because a person who's a LES score is a 12, they actually look a lot different. You can have a 12 who's really not very functional, or a LES score 12 who's actually doing quite well. I'd say a solid number is somewhere around 14, 15, 16. Those numbers and higher, it's really difficult. But the gray range are the 11, 12, 13 range, because we've transplanted some of those boys and they're actually doing pretty well. The other half of those boys are not doing well. And trying to predict that outcome is really like threading a needle. And it's not just about the score. So that's why I put all that work up. NFS plays a big role. The amount of protein in your spinal fluid actually predicts outcome, and some of the other things. But yeah, those are the ranges of numbers that I give families.
Terms of the results in adulthood, there's clearly a relationship between the pattern of involvement of cerebral involvement with the inflammation and the outcome. For example, we recognized that patients who had a cerebellar involvement all had a very bad outcome. Patient with a frontal involvement may have a Leukodystrophy score of 3 only, but they have a bad outcome versus a 3 in the posterior region. So we're not looking only at numbers or score, Leukodystrophy score. It's a help in some way, but the pattern of involvement and the clinical symptoms are, in my eyes, more important for the decision if somebody the outcome would be beneficial or not. Yeah.
One more comment. I think we want to take a break and then just have one more quick comment.
So, I think part of the issue is that when these boys that are diagnosed with a score of 12, we don't have a history of how long it took them to get there. And there may be some boys that have taken 2 years to get there and some boys that have taken 6 months to get there. It's those numbers, I just made that up, but you get the sense. So it's, you have a 12, but you only got one time point and you don't know how fast people are progressing. And maybe that's part of the issue. But it's hard to know how to fix that. So.
Oh, I was certainly not commenting on on anything MRI Leukodystrophy score. I had a question actually, and it relates to what Wolfgang said, because you have all these different regions that are affected. So, are there particular scores or regions that you say, okay, if this is infected or involved, then it's much worse than if you get 12 points, but they come from these regions? Oh,
guys probably know. Wolfgang probably knows best of Morgan and Morgan best.
Well, yeah, so I think the question was, so you got a score of 10, but that's a cumulative score, and you can have different areas of your brain that are affected to get to that score. And so, are there key aspects of the brain that, if they're affected, correlate with a better or worse outcome? And we need to do that analysis, but we haven't.
So anyway, let's take a break. I know these guys, they can talk forever. I know them really well. So, but we do have still 3 more talks, and I know everybody needs a bio break. So let's take off about 10 minutes. So maybe around 11 to 11:05, we'll start with or without you. Okay.
Kelly wanted me to remind you to talk about the deal.
In my site, but I can talk about it.
Mention it.
Yeah, yeah.
Okay.
And what is that?
This is on? Oh, okay. Okay, why don't we get started? I know there's some people still rolling in, but if you could have a seat, please, everybody, so we can get through this. Yeah. All right, go ahead.
Okay. Yeah. Great. So nice to be back in person again, and share this forum where we can come together, ask questions, make progress together. So, and argue with each other. So I'm going to be speaking about symptoms in women with ALD and hopefully address the question that was raised earlier. Just briefly here, my disclosures, PI of various trials and founder of Swan Bio. So up to now, we've been talking mostly about the disease course and stages in boys and men with ALD, and a pretty well-defined landscape of cerebral ALD risk in childhood, AMN in adulthood, and the risk of adult cerebral ALD. I think what is quite clear is that this landscape is less well-defined for girls and women, and it is becoming more pertinent for the entire lifespan, not only because of our knowledge of the symptoms in women, but also because of newborn screening picking up girls with ALD. And as was mentioned before, we are now moved our consensus statement to revise the term carriers, as women can manifest with symptoms, so that we speak about asymptomatic and symptomatic women with ALD. Years ago, Mark Engelin already mapped out symptom status and age in women, showing that over time, an increasing percentage of women were becoming symptomatic, pointing to the disease burden in this population. Symptoms that he described in this first paper in Brain, 2014, listing symptom signs and EDSS scores, highlighted many symptoms related to myelopathy, spinal cord disease, and neuropathy. And I want to start here by explaining some of these terms, which will hopefully help us understand what is happening in women. So myelopathy in men as well as in women refers to a long tract axonopathy. Our joint mentor, Hugo, used to use his big arms and wave them up and down, describing the cortical spinal tract and the dorsal columns. And these bring information down from the cortex to the spinal cord and muscles, and send sensory information from the periphery up through the spinal cord to brain. All this affects gait, balance, bowel, and bladder function. Neuropathy, on the other hand, is the peripheral nerve mediating position sense, discriminative touch, and pain. So it's important to know what these terms mean when you're going to the doctor and you're hearing about myelopathy versus neuropathy. When we started analyzing symptoms in our adult cohort, focusing on bowel and bladder symptoms, this is work from Camille Kaur, we found that there was a significant proportion of the women who exhibited myelopathy symptoms. And more recently, Natalie Grant in our group has pointed to this neurological disease burden in women with ALD, showing here the distribution of first symptoms in 75 women with ALD, ranging from gait, walking difficulties, very prominent pain, and probably more pain than we're seeing in the male cohort, urinary and bowel symptoms, interestingly, often more prominent bowel symptoms than is reported in men. And the time to onset of myelopathy symptoms, while not as early as in the men, is significant here and pointing to a real disease burden in women that has so far escaped our attention. So what are the symptoms of myelopathy in women? We talk about weakness, spasticity, muscle spasms, sensory disturbances, bowel and bladder symptoms, and importantly also balance problems. When we're doing a neurologic exam and we're talking about spasticity, we're often following various different signs, such as tightness at the ankles, upgoing toes, looking for any kind of abnormalities in foot position, scissoring of gait. And these are important symptoms that and signs that impact also gait and balance. When looking at this compared to men at MGH, we find that disease severity is quite comparable between males and females in the moderate and severe stages. We've been trying to measure how balance is impacted in adults with ALD using an apparatus in the vestibular lab next door at Mass Eye and Ear, where we can measure the degree of sway when exposed to changes in visual environment or with surface perturbation. So you can see you're here in a harness and experiencing changes in the surrounding as well as on the surface. And not surprising probably to many of you who are experiencing daily balance difficulties, if you are challenged with an environment that is visually not as clear, maybe it's darker, maybe the surface is uneven, you're more prone to fall, you're more prone to be off balance. And these kinds of this vestibular input, this integration of information from periphery up to the brain is impaired in adults. And this is true for men as well as women. Urinary and bowel symptoms in adults encompass everything from urinary incontinence to that is found in our cohort in 64% of men, 68% of women. Bowel symptoms more frequent in women, and I think this is similar to what the Amsterdam cohort has also seen. So we might have a selection bias here because we are seeing a lot of symptomatic women. Those are the women that come to see us, but at the same time, it's important to note that this disease burden affects them on a daily basis, similar to symptomatic men with AMN. So the impact of urinary and bowel symptoms is aggravated by the gait and balance problems that patients have. Once you have the need to rush to the bathroom, you're really relying on your motor system to react, to get up and go, the ability to walk, stand, and the way your brain processes information is hugely important here. Patients who experience fecal urgency that has caused incontinence reported a mean warning time of 3 minutes. Patients who experience urinary urgency that has caused incontinence reported a mean warning time of 4 minutes. And so you have to imagine now you're getting yourself to the bathroom in those situations. And this is where further burden and accidents can occur. So I think this is an area that we're trying to raise awareness around and also find more remedies. Briefly to highlight cerebral ALD and movement disorders in women. Cerebral ALD together with adrenal insufficiency is a very rare occurrence, and but we do think that in the brain of women, cortical connectivity can be impacted. This is by no means what we see in men with ALD. So demyelination is extremely rare and not something seen in women. We have had one woman who's shown inflammatory demyelination, but she also had adrenal insufficiency present. And in the end, we recognized that there was 100% skewing towards the abnormal X chromosome. So I actually have started to use ACTH as a simple screening tool in women. If there is adrenal insufficiency, I'm a little more prone to then pursue more aggressive monitoring of cerebral ALD. But at age 25, she had leg heaviness, pain, and episodes of falling, had been misdiagnosed with multiple sclerosis, then had elevated very long chain fatty acids. These were also elevated into a male range. So this poor woman had cognitive decline, cerebellar symptoms, and sadly succumbed to the disease. There have been occasional case reports, but I wouldn't say there are more than a dozen across the literature of the last 20 years. Occurrence of cerebral ALD is only in a woman in the rare event of both alleles being affected, and that highlights the importance of gene dosing. So movement disorders in women, this is also a new topic that we're trying to understand, having gone back and recognized that many women have reported torticollis. Actually, some of the first reports in women historically have highlighted the fate of the boys that have cerebral ALD, but missed the fact that these women often had movement disorders, and these can range from head tilts and neck tilts, and as well as different kinds of positions and dystonias that I'll briefly talk about. So types of movement disorders that we see: hypokinesia, hyperkinesia, meaning everything from too much movement to too little movement. Too little movement often being the kind of bradykinesia that is akin to what you might see in Parkinson's, as well as too much movement, balance problems, dystonia, restless leg, and tremors. So we've seen a specific constellation of women who have movement disorders that encompass cervical dystonia, neck, head tilts, twists, shifts to one side. Often those come on earlier in life, and some of them get better, some of them don't. Some women require Botox injections to relieve this. Tremors are quite frequent in not only in the lower extremity, but also in the upper extremities. And then voice changes that also occur, spasmodic dysphonia, and something that we think is related to this type of constellation of different movement disorders. So here an example of a woman who came to me 2018 who had some head titubation, and then over the course of time developed increasing dystonia, and tremors worsened with specific positions. So this is not uncommon. I think in a dystonia population, such as X-linked recessive dystonia, Parkinsonism, Fragile X-associated tremor ataxia syndrome. So I think there's some precedent to pursuing this in women with X-linked disorders, but it is early days and we have still much to learn. We've found that restless leg syndrome is also another frequent finding, where women report the urge to move their legs, have uncomfortable sensations, usually experience it in the evening, sitting or lying down, and moving eases the unpleasant feeling temporarily. Here, just an example of what that can look like in terms of the restless leg syndrome movements seen. So we did a pilot study in 32 adults, found that 40% of these had evidence of restless leg syndrome on a validated phone interview developed by Johns Hopkins. 48% of women were found to have RLS in this cohort more commonly than in males. Prevalence is substantially higher than the general adult population. It's still a small cohort, but we know that in the general population that numbers are probably closer to 5 to 10%. Those with RLS also had more signs and symptoms of a myelopathy, suggesting that this might be related to the spinal pathways contributing here. And you can see here the positive RLS symptoms in patients with spasticity and other myelopathy symptoms, about 10 to 20% higher than those that had were negative for restless leg syndrome. So pain, lastly, in women with ALD involves both peripheral and central nervous system. And I'm going to briefly focus here on small fiber neuropathy aspects. A lot of women come to me with swelling in the feet and discoloration, and this is associated with pain. We know of an entity of small fiber neuropathy that likely plays a role here, where you can analyze the skin and find evidence for absent small fiber nerves. And there was a first study actually out of Norway looking at small fiber neuropathy in adults with adrenal leukodystrophy and finding a high prevalence of this in women. So I think this is another area where we need a little bit more definition over time, and it is also a treatable condition. We've been focusing on an important hub for pain and sensory information, the dorsal root ganglia, which is adjacent to the spinal cord and brings sensory information up into the spinal cord. And we've found that actually mice that are lacking the ABCD1 gene have a heightened sensitivity, and this is seen around 6 to 8 months of age in these mice. And they also have an increase in certain mechanosensitive channels that mediate pain. Piezo2 is elevated in these mice and associated also with an increase in not only very long chain fatty acids, but also certain markers of scarring, such as GFAP. Piezo1, Piezo2 has received some attention last year due to the Nobel Prize in Physiology being given to the person who discovered them. We've actually been fascinated by this also, not only because we see this relevant to both mice and humans with ALD, but because the levels of very long chain fatty acids in the nervous system are highest within the structures of the dorsal root ganglia. And we were able to partially rescue the heightened sensitivity in the mice using blockage of piezo2. And lastly, piezo2 might also be modified by changes in the membrane structures. Remember that the membranes of our cells are made up of lipids, and these lipids are composed in part of fatty acids that could be very long chain fatty acids as well. And we find that if you find very long chain fatty acids within those membranes, these piezo2 channels could be modified, and incorporation of very long chain fatty acids may therefore make these membranes more prone to pain and heightened sensitivity. So many questions here ahead. I just want to lastly point out that leg discomfort in women could have a whole variety of causes, and I hope I've been able to highlight that these can range from neuropathy to vascular insufficiency, spasticity, as well as restless leg syndrome. So it's important that you don't, with your symptoms, simply attribute it to one pathway alone, going to a physician who understands how to differentiate this, to treat this accordingly, to understand how activities of daily living might be impacting this, how physical therapy, how other adjunct symptomatic care can be helpful. And we are about to launch a first trial for women ALD, looking at leg discomfort. And then in those women who have restless leg syndrome, performing a placebo-controlled trial using pramipexole, due to my experience that women who get better sleep with pramipexole have a better performance in gait and balance. And this is, I think, something that we can assess in a very short time and perhaps make a meaningful difference to women suffering from symptoms day to day. So just to conclude, most symptoms in women are due to myelopathy and neuropathy. Some symptoms are due to deep brain nuclei dysfunction, something that's still poorly understood, but I think that we're making some headway in mice and humans. Extremely rare is brain demyelination and adrenal insufficiency. We only get a baseline MRI for women. We don't recommend yearly brain monitoring, but I do think it is something to keep in mind if very long chain fatty acids are elevated into the male range or you have adrenal insufficiency. Chronic progression in women is amenable to lifestyle changes and medications. And I think it is hopeful times. We have new trials and treatments underway, not just for men, but now also for women. And clearly we need a lot more, but it's a start. Thank you.
So, the other two topics are not directly related to this.
Lisa? Yeah, I think exercise for sure, stretching, level of mobility, I think is important day to day. As similar to men, women experience a lot of freezing of the limbs and pain after prolonged sitting, standing. I think these are things that lifestyle changes can make a difference in. It's not one size fits all again, but I've found many women who've come back after making a concerted effort around daily routine and weight loss, dietary intake, things like that can make a difference. Yeah.
I just need to review the difference between myelopathy versus neuropathy.
But myelopathy is spinal cord, and neuropathy is the peripheral nerve that goes from the spinal cord out into. So pain can be referred pain, or it can be pain directly due to injury at the site. So just because you feel pain a certain place doesn't mean that is where an injury occurred. But yes, you can have women experience distal limb pain. They also experience back pain, neck pain. It's not uncommon. Emma? Nothing consistent. And I will say, I know it's a big topic. I've always been impressed at what these women have accomplished, in care for others and their families, their children, and the amount of, anxiety and psychological burden that comes with that is enormous. And sometimes it's important to, try to tease that apart from, what might be a more, structural change or difference in cognitive performance. So I think it's always good to look at that in different settings and scenarios. Are you able to keep up with your job? Are other people saying this to you in your work situation? Is your sleep good? Are there, you have to look at it holistically. Sorry.
Yeah. related to that, so there is a, like Florian mentioned, there is a significant group of people who have what we call a small fiber neuropathy. And the small fiber neuropathy can cause what we call orthostatic abnormalities. So your positional changes that can affect your blood pressure. And because those blood vessels are regulated by those small nerves. And so consequently, there are people who have what we call like orthostatic hypotension or postural orthostatic tachycardia syndrome. And those individuals, they may just have chronic fatigue as a consequence and have performance issues that are not because they have a brain disease per se, but it's just because they're just not getting, and so that often can be treated well with changing their hydration status. Sometimes we use steroids, a different type of steroids, not like prednisone or different kinds to bump up the blood pressure, and we can see their improvement. So I think that the challenge here is that we always try to sort of make it all fit one, and like you said, it's not, right? So that's why that detailed evaluation, like Florian showed, this sort of, when you have pain, it could be many things that cause it. It's not all just because of spasticity. It's not all just because of neuropathy. So getting that more detailed evaluation often helps us to come to that sort of conclusion.
Oh, yes. I was on a roll. But just to remind those who may not know about it, on July 22nd is a patient-focused drug development session with the FDA. Very, very exciting, and is the opportunity to educate FDA and raise awareness around symptoms and the burden of illness in all adults with ALD, men and women. And I think I know many people, and it's been a whole village that's worked together to make this happen, and many patients who are providing valuable testimony here. And ALD Connect has partnered here with many organizations, including ULF and ELA and many others. So go to the website of ALD Connect to find that link for July 22nd, patient-focused drug development. I think this will be such an important resource to, highlight the unmet needs here.
You had that slide early in the presentation of, I think, the Kaplan-Meier of symptoms or no symptoms for AMN versus women. Is that published somewhere?
No, not yet. No.
Yeah, there's a picture with Grant up in the corner, but
Yeah, she presented at the American Academy of Neurology in the spring, but we haven't published it yet. On my to-do list.
So we know your study is of women, and they have not been studied that much. But are you conceiving of these results then as female specific, or catching up with what we historically see with men with AMN? I mean, having heard about the studies with men with AMN, everything you're saying about women sounds familiar based on that. So are you saying this is peculiar to women, or it's just that, it's the same thing?
So there's some shared aspects, but there are also some distinct differences. Okay, so women clearly have myelopathy, neuropathy. They don't develop adrenal insufficiency or brain demyelination, and among the myelopathy symptoms, they have more pain. They have movement disorders we don't see in men. So there are some things that really seem to be different, and why that is still not clear. But I think it's something we just have to investigate further. I'll be around.
Yeah, I agree with Florian a lot on that. It's family. Okay, now we're going to talk about the future. So this is about upcoming clinical trials, and Dr. Mussolino is going to start first and talk about cerebral ALD trials, and then Dr. Kohler is going to go back and talk about AMN trials. Simultaneous from Mass General Hospital as well, by the way. So,
that's all good. Good morning, everyone. It's always a privilege to be able to get so close to you guys and get to know the stories. So please come and talk to me. I'm one of those that has a hybrid practice. I see kids and adults, but Dr. Eichler has been my mentor, and I started to look at the vessels, and he went further and further into how the vessels alter the white matter and cause leukodystrophies. So I don't see you guys in clinic, although I have more than 200 patients from Latin America that I consult for. So I don't have a clinic, but I have a massive clinic in ALD, but I really, this is what keeps me going. So please talk to me. It sounds like desperate. I'm teasing you guys. It's a pleasure to be here. I put it on presentation mode. Do you need anything else? I'm not going blank. Oh, now it's coming. All righty. So I'm going to try to be brief and just highlight what we are getting to see on a new study that has been going on for a couple of years for kids, boys, with childhood cerebral ALD. And I want to make the shift change because we're talking about women. But you just heard about bone marrow transplant, gene therapy, and how that alters or not the disease in cerebral demyelination. A little bit of the disclosures. I've been working with lots of different companies that are trying to get into the space of ALD and treatment. And I also primarily have funding from NIH. And of course, a lot of the things that got me started were from foundations. So very important contribution. I'm going to briefly remind everybody that we start, let's say, with newborn screening. You have a boy that has ALD, and you scan that kid, and that's why we don't do it at birth. The MRIs will be normal, and they will be normal for several years before we can see that a lesion starts appearing. And it's usually, I don't know how much you guys look at MRIs in your spare time, but those pictures that you've been seeing and this thing that is here is basically a slice of the brain in this direction. So the nose of the patient will be up here, the back of the head will be up here, and you have to imagine that the feet of that person are coming towards you. So this is the left, and this is the right side of the brain. The white matter in the sequences that I'm going to be showing is black instead of white. And when you see white, that's the lesion, okay? So just a very basic, like ABC of neuroimaging right here. And so you're born with a normal myelination pattern, and the myelin develops over time. And then at some point, and the most common time when the disease starts to appear is around 4 to 9 years of age. And you get a lesion in the back of the brain most commonly, but you can have a lesion in the front or a teeny one in the tracts, the long tracts, the Hugo Moser hand that go up and down are going in the brain in this area. And I'll show you because we do have cases of that in this study. There is another aspect. It comes in a different sequence. That's why the kids are in the MRI for 45 minutes, which is this one where we put contrast in the vein of the kid, gadolinium. You're going to see it in the presentation. And it shows out into the brain parenchyma. You see white here is the contrast, and there is no contrast in the rest of the brain as it should be. And this tells you that the vessel barrier, where the gadolinium is circulating towards the brain barrier, has been disrupted. We call that the blood-brain barrier. And this is what triggers the transplant in most kids. So you see these lesions appearing, and then they develop this kind of leaky in a different sequence. So the lesions are still there. Behind that, there is a larger kind of lesion in the white patch. And that's going to be called flare or T2. And when the leakage appears is when we think the lesion is going to start turning on rapid progression. And that's why you go to the transplant centers and start the process of transplanting. In fact, in newborn screening, we are getting HLA very soon, around 2-3 years of age. That's to be ready when the lesions really become amenable to the treatments that we know so far, with all the data that Dr. Orcad and Troy Land have been really putting out and working with these patients. So we know if we don't do anything when the lesions are active, most patients, 90% of them in this age group, kids, boys, less than 12, are going to go on and develop that lesion and grow it as a wildfire in the brain. And there is a window to stop this disease, which is early. And that's important too. And we use this Lowe's score that you heard. And just for, it goes from 0 to 34. We like to treat, when possible, less than 9. Okay, so it's a small window that we have. And that's why the kids are getting the MRIs every 6 months. So I think this is background, but it's a little bit of a help on why we did this study. And we're trying to understand what it can do or not. Now I'll zoom into the brain, and this is a schematic. And imagine that this is a little vessel, and this is a vessel wall. Okay, so here is the blood in the middle. And you have these inflammatory cells, we call them leukocytes. And they should stay outside the brain. This is the brain here. And in ALD, once you lost the gene function, ABCD1, these cells become sticky to the endothelium, which is kind of the gatekeeper. And if you get another insult, which we don't know what it is, what is that threshold that makes it cross, you can start having cerebral disease. And that's why not all kids will develop childhood cerebral disease. Although when we look over time, most boys will end up with a risk of developing cerebral disease over their lifespan. So what we are trying to do is to try to normalize this stage so we can prevent that. And unfortunately, this, what we see here, we think is what you see on the T1, the leakage of that contrast we put in the vein is when this thing is open, we start seeing that leaking with the cells, leaks the contrast, just to put it simple. And that's where we are doing almost treatments. It would be ideal to get earlier, but we lack a lot of understanding of how this really can be read on a patient. As you guys know, newborn screening is changing how we are able to monitor these lesions, and that has changed now our understanding of what these lesions really look like when they start. And I just want to point this picture, which is a patient that has a dot, and 6 months later has a bigger dot. This is millimeters, not even 2.5 millimeters. And then another 9 months later from the baseline, it has this teeny tiny lesion. So we were talking about, oh, big lesion in 2 years, you're in vegetative state. Years and years ago, when we were diagnosing these lesions with Lowe's scores of 8 or 4 or 5, we're now on Lowe's score of 1 all the time. And this is what we don't know. What we don't know is how long it takes you from that teeny little dot to a lesion that really will pick up speed and end up developing the really large lesions. This also, I use this schematic to demonstrate that you can have lesions in the back of the brain, most common, the majority of the patients, but the lesions can be also in the anterior part of the brain and also in the tracts, the long tracts that go up and down. And this is just in one slide that we can see them. So Dr. Eric Malak at Cornell, working with Florian and me, have characterized those early lesions in all the patients that we have before they go to transplant. As you can see, it's very short follow-up because they are going to treatment. And I don't know if it catches your eye, you see patients that have no lesions, and then when the lesion develops, the growth in volume, and from now on, I'm going to be referring to volume growth, really exponentially grow when the lesions are going to progress in early childhood. And we do know that patients that the lesions stay the same volume end up arresting. We call that halting. And we hope that the treatment that we do to these kids will do exactly the same thing to the lesions. So this is the lesion in the back with a Lowe's of 2 and lesion of a Lowe's of 9, 18 months later. These are not the same patient and they're kind of schematics, but just to give you a sense of what we expect the lesions to do once they have gotten into this stage where they get around that tract, which is the corpus callosum, the splenium. So the study is aiming, and it has already recruited 14 subjects. When we do research, we don't call them patients. It's not patient care, is a study, and you're consenting to that. That's why you're going to see the word subject, not patients. But we recruited 14 subjects, 8 of them with the gadolinium, with already the leakage in the lesions, and 6 of them without the leakage in the lesion, which we consider a stage prior to when the lesion starts speeding up in the growth. And I'm going to be showing you some very, very preliminary data, and I want to caution everybody with any hopes or not, because this is very early data, and we really have to continue study this drug to see if there really is an effect as we are insinuating here with the results that I'm going to be showing. So I'm going to present the first six subjects, patients, boys, that got to the 6-month mark of follow-up. And I'll show you the data that we have on that follow-up. And you can see that there are some of them without lesions with contrast and some of them with contrast in those lesions. And the study has been developed that way. We have a population, so a group of boys that have the lesions without the contrast yet. And then we have another group that have lesions with contrast. And this is where you can see the leakage in the blood-brain barrier. The study also based on this early lesion volumetric analysis, we knew that the age makes the lesions grow change. So the more you get into teenagerhood, your growth pattern changes and you slow down that rate. So the study was designed to stop where we see most of the change in the growth of lesions. So the patients are not being enrolled beyond 12 years of age. That's important because we're trying to capture the boys that have the fastest rate of progression to see if the drug has or not an effect. And they have to be asymptomatic pretty much, like the same thing that for gene therapy we did. And then this is what happens. This is an oral drug, could be liquid, it could be a tablet. It's taken every day. And then we do different visits. And as you can see here, you have a visit at 3 months when they get an MRI. At 6 months, they get an MRI. And then they do it every 3 until they get to this visit. And then we do it after the year mark every 6 months, like the normal regular screening for those patients. And if the lesions continue to rapidly grow, or if the contrast that was there didn't disappear, or there was no contrast and they turn into a contrast lesion. So whenever we see that the lesions are kind of moving fast, these patients go to bone marrow transplant. So one of them went on to also into gene therapy with a 6 month in between, but the majority go to bone marrow transplantation. And here are the results of what we've seen so far. And then I'll show you at the end a comparison between what this drug that is called leriglitazone and is overall an anti-inflammatory drug that we think has effects on the microglia, on the vessels, on the leukocytes. We've done a ton of studies in vitro in different tissues and different animals to see that there is an effect, but the truth is that we have to see the effect on the boys. And this is what we saw on the first one of the first subjects. And you can see the lesion here with the little white dot. And this one had a little bit of leakage. And then you can see what the lesion looks like 3 months later. And the lesion looks like at 6 months. And you can see it has changed, it's growing. And then we do a lot of real quantifications. If you look at what I was showing you before, the losses is still the same number. So this is not a study that is really capturing a loss change. These are for the very early lesions, loss of 1, loss of 1, loss of 1. But you can see the lesion, I just showing you the pictures, the lesion is growing. The question is it growing at the same pace that the disease will do by itself, or is it slower growth? And it's looking more like when we do bone marrow transplant or gene therapy, where the lesions continue to grow for some time, and then they halt. And that's the normal response to a therapy. They don't halt the day that you do the transplant. They hold in between 9 months and a year and a half on the lesion volume. So this is what we've been trying to look at, that rate of change. And again, if we plotted the lesion here growing and the blue and orange are different ways of controlling for every possible other thing. So the white matter in the whole brain. This is the growth for this patient in particular. And in dotted lines, you can see what the lesion would have looked like if we started with that volume and we apply the natural history, what we know the lesions do based on the work that Dr. Eric Malak has published and others. And this is now projected so this is kind of a zoom. And here is like the natural history growth, kind of how it picks up exponentially and grows that way. That's usually the nature of growth of these lesions, according to the natural history without treatment. And this is what this lesion is doing with treatment. I have another patient here, and I am marking here, this patient does not have contrast enhancement when it starts, and it continues to not have contrast enhancement. Here we have, again, a patient follow up to 6 months. And you can see the lesion in the back. It looks slightly bigger, but pretty much the same. When you plot it, this is what the volumes look like. Again, in a zoom, this is what the natural history. This is the scale. That's what I'm pointing at. And this is basically what the lesion should have done. This is what the lesion is doing at the moment, up to the point that we are following this patient. Another patient, and this one I picked to show that long tracks. The little lesions are less common in the boys. But if this patient had both, had this one, and it had the lesion in the back. And you can see this one is exactly what I was showing you in the beginning. Little dot, a little bit bigger, and then a little bit bigger. And if you look this, you will say, well, the lesion is growing. I'll show you a picture a little bit lower. And this is where you have to be careful. It does be kind of growing, but when you look at it, this looks much less prominent than the growth that you see here. And that's why we measure the entire lesion on the volume. We don't just pick one slide and score it. We just like literally draw every single way that any single place that we see the lesion and make a volume. So this lesion is doing this growth. Okay, this is controlled to the normal appearing white matter or the whole white matter of the brain. Again, here will be the growth expected as per the natural history. Now here with a different scale, you can see the natural history will have grown like that. And the patient lesion is growing like this. It's pretty much flattened to what you would have expected. Another patient, and this one has a longer follow-up, and that's what I included it. Again, this patient, we did give it a little teeny tiny dot of contrast at the beginning, but pretty much no contrast enhancement throughout. And this patient was able to stabilize the lesion as well. And you can see also, this will have been natural history. This is what the lesion is doing and kind of plateauing completely. But when you also plot it in terms of rates of progression, is very different than what we learned natural history, meaning untreated lesions, would look like. I also have a patient that has an anterior lesion. Remember, we were looking mostly the posterior lesions. So now the lesions in the front of the brain. This one had the classic, pretty aggressive contrast, meaning a lot of inflammation. And this is what we've seen at 3 months and here, I'm sorry, 3 months and 6 months. And even the contrast was coming down in intensity. The lesion, pretty much the same in volume. It has little new areas here. This patient went to bone marrow transplant. You can see here the volumetrics and what the lesion looks like. Again, a lesion that plateaus in volume. It doesn't continue to grow significantly compared to the natural history. And this kid goes to transplant and successfully comes out of transplant without lesion progression or contrast. Without contrast after the follow-up. But you can see what we also see in transplant is that the lesions, even though we are treating with bone marrow transplant, continue to grow. And that's our experience also in bone marrow transplantation. There is a normal expectation that this white patch in the T2 will continue to grow. And the contrast tends to disappear around 60 days as an average for most patients. We are not seeing the contrast disappear in these very few patients that we have, but the lesions are halting the growth, which is what I'm trying to highlight. We are also looking at other aspects of the MRI, and this is just to show that the lesions in the T2 can look like that. This is a 3D reconstruction, but there are a lot of more changes in the brain that you're not seeing in the white patch. And that's changes in the microvasculature, the mini vessels that are in the brain in the white matter. And we can see those in the MRI. And we use 2 parameters, one for the leakage and one for that sluggishness of the flow when the inflammation is starting to occur. And this is just to show you 2 examples that had a little bit more follow-up. And what happens with this, and here going down is good. Let's believe me what I'm saying. and this is that sluggishness of flow, and pretty much this lesion that is followed up to 46 weeks. You can see has changed dramatically, not only in the lesion, but all over the white matter. So in the normal appearing white matter, all around the lesion and in the lesion, these parameters of how the vessels are working and the inflammation overall seems to be going in the right direction. And this is a leakage, is way more sensitive than that little dot of T1 contrast gadolinium. And they also seem to be decreasing in a significant way and in the right direction. This is for that anterior lesion, just to put it as a comparison. We do not have this time point, but we were able to see the similar trend on these 2 very significant parameters because we published and shown that if these ones are higher, your lesion will progress faster. So going lower, it means that they are decelerating, that the lesions are halting or in the way, hopefully, to halt. So then we compare it, and this is the last Couple of slides. This drug that we call leukodystrophy, MIN-102, is the short. And then the allo HSCT, which is the bone marrow transplant, the conventional treatment. And you can see the ages are pretty comparable. This is the MGH cohort for the bone marrow transplantation, Dr. Eichler's clinic. And we compare these patients, and I want to note that these have much more longer follow-up than the patients that are in the drug in this new study, because it's a new study and we don't have yet the data. But will come as we are now completing the enrollment and the patients continue to be scanned. And this is what we found. So what you see here in red is the lesions growing with the natural history, and you can see kind of more verticalizing, like growing rapidly. I put the schematic here, what it would look like 18 months after a baseline. And then this is what we're seeing so far with the green, which in here is the leukodystrophy treated lesions. And then blue is the bone marrow transplantation with the small lesions. We have a larger cohort, but we just took those boys that went to bone marrow transplant with the small lesions like the ones that we are showing you here. In fact, maybe these two are a little bit larger lesions than what we're seeing in the trial. So this is another way to show this, and I want you to focus here. This is, if you don't treat the lesions, how many cc's per month is gonna that lesion grow, relative growth. And this is what they do without treatment. I want to point out there is variability, so every patient needs to be treated as a single person. So really customizing the approach is the most important thing for anything that we do in any disease, but most importantly for cerebral ALD. This is what bone marrow transplant does. It really holds that growth rate, okay? So they're growing slowly, little, is not zero, but they're much less than if you don't treat them. And this is what we're seeing with the drug, which is more resembling a bone marrow transplant than a natural history. I want to point out that the limitations, you see the longest follow-up here is 9 months, while in the bone marrow transplant, we are talking about 1 year and 24 months. But this is the rate per month that you will have if you were treated or untreated. So there is something here that shows a signal that these drugs may be able to really hold those lesions in a very slow pace of growth. And that's the most that we can say at the moment from what we are seeing. And this is basically the conclusions. Early lesion progression in pediatric or childhood cerebral ALD is poorly understood. And I want to say that because we still need to understand that. And newborn screening and the number of kids that we're following are going to answer those questions. 90% of the cerebral ALD lesions grow exponentially without treatment. When you treat with transplant or gene therapy, we have seen today that they slow down and are able to halt cerebral lesions. Leukodystrophy appears to slow down the growth with similar rates to the transplant. We don't know yet if it can halt the lesion. And I want to be very clear about that. Longer follow-up and more patients are needed to determine that. And the study continues. We have the full enrollment, and the European regulatory agency, the EMA, have asked us for all the data at 6 months to see if they want to pursue any type of approval. The trial has been executed primarily in Europe with patients from all over the world flying to European sites, Barcelona, Göttingen, Hamburg, and Paris. So I think with that, I didn't put a lot of pictures today, but I really want to thank all the advocacy groups and the families themselves for bringing yourself together. These things are not found. Every patient that found the study didn't do it because we have any web page. We did it because they found another family that knew, or an advocacy group that knew that the study is being executed. Thank you to the Minorex team to take cerebral ALD on. They're a small company and they're really trying to make a difference. And I have to thank the Martino Center for Biomedical Imaging. There is a troop of scientists trying to make this processing of the MRIs fast enough. So in 72 hours, we can tell the investigators, hey, the lesion growth is this, is that. And that took a long time to set up because it's a pretty short timeline where the doctor treating the patient needs to make decisions. Do we send them to transplant? Do we do something else? So we are hopeful, we are thankful, and we continue to study and be very transparent with whatever we learn or not from this study. Thank you, guys.
A couple minutes.
Thank you, Patricia, for the presentation. Really wonderful, and I really like how you explained it and made it so clear. I missed one part because leukodystrophy was a drug for AMN. So how did you identify? Because you're talking about these blood vessels and the leakiness and stickiness. So what was the connection from an AMN drug to this work on the endothelial cells? And
there is the company took on working with a bunch of collaborators, Johannesburg, in Vienna, our laboratory, and many others, and some CROs. Very early on, while advanced trial, the AMN treatment trial was going on, to see when they were looking at the plasma, they were seeing some signals that the blood-brain barrier was changing. And they went on a study if the drug could normalize the blood-brain barrier. So that like endothelial. And we know that we don't have a mouse model. So we cannot go to the mouse and treat the mouse and get the cerebral disease to go away. Maybe a ZAT is going to give us that tool at some point so we can start treating and seeing if treatments work in a mouse model before we go to the patients and do these kind of studies. But they published already Pisueta, I think in clinical translational medicine, all the results like co-joint. So they look into the treatment in rats in the AMN with the drug, and they saw that there was some decreased activation of endothelium. That we looked in my lab at ABCD1 deficient endothelium and pericytes, and we exposed that to the drug, and we look at permeability to inflammatory cells. They also look at a more complex blood-brain barrier with another CRO, and they also decreased the permeability. And those results were the ones that encouraged them to pursue. Nexus was in the works since 2018. And Advance is just enrolling patients at that point. So this study was already being proposed because they thought the anti-inflammatory effect and the neuroprotective effect of the drug maybe could have an effect on very early lesions. And we know that advanced lesions are very difficult to treat. So they develop everything to be able to say, can we offer something that maybe delays the bone marrow transplant or maybe prevents some kids from going into bone marrow transplant? And I take the opportunity to highlight that bone marrow transplant is very difficult in the developing world, guys. And patients die, not 10%. We have more than 30 to 40% mortality when you separate the cohorts that come from the developing world. And the delay to transplant for a patient in most countries in Latin America is an average of 6.5 months. In the US, Dr. Eichler, 5 weeks, they're in transplant. 1 month versus 6 months. So, and a lot of the banks don't have matches to offer. So the unmet need for cerebral ALD is still there. And even with transplant being a possible treatment, it's not always accessible to a lot of patients. So that's why we're trying to look for other ways to treat. Excellent questions. In the boys, the side effects are very, very low. We see a very transient edema or not at all. The majority of them don't even get it. But from the adult patients, we know that they can develop significant cerebral edema, leg edema, not cerebral. And that usually it gets better if you dose very slowly. And that was also the way that this study was developed. We start with an estimate by the body weight, and then we do a little escalation to get the patients to tolerate it better. But in the boys, we have seen almost no severe side effects at all, and only very mild edema at the beginning of the treatment. Very early, guys.
So the boys that participate in the trial, you said they come from families, and so are these? Well, in Europe, there's no a newborn screening yet, but so are these from extended family screening? Because you pick them up so early, so they must be completely asymptomatic. So yeah.
The majority are kids that have siblings.
Yeah.
They've been doing their MRIs every 6 months or every year. So sometimes in a lot of these kids, the MRI don't happen for 6 months. Yeah. They can access the MRI. And we had all kinds of things during the pandemic too. Like the scanners were down for pediatrics in all countries. So you couldn't get scans because the hospitals were dealing with the COVID patients and their healthcare capacity was maxed. So we had a lot of kids that had no scans for a year and a half that we are seeing now with advances. I want to also highlight we have, unfortunately, around 15 to 1. So 15 patients we screen, the lesions are too large. They're coming from a lot of places in the world.
So extended family screening is extremely important. Yeah, so because there are your candidates for, especially when you talk about developing countries, the chance of picking up these kids so early with MRI is 0, I think. So yeah.
So Moser has made available for free to any physician anywhere in the world the dried blood angiocardiac system. So, and I want to say this because for these families to ask anyone to do angiocardiac is almost not possible in some parts of their country, even countries where the healthcare system supposedly works like Argentina.
Yeah.
You're far away in the mountains. That's not the case.
Yeah. And the beauty of the blood spot is that you can send them a regular meal. You save one, and then yeah. Yeah.
That is gonna after we take the results because we need to screen for identification. So we need to start screening for cerebral disease. The other family members to get screened, and she does it for them too. Yep. There's no way to thank her. I think tonight is a good opportunity.
Yes.
If you want to honor this work.
Right. One last quick question.
Oh yeah.
I would like patients to ask questions.
That was beautiful. I'm sorry for hijacking, Ali. Do you think there's any role for this treatment in children that are too advanced to receive gene therapy or bone marrow transplant?
Unfortunately, to be able to do compassionate use, you need a drug approved. And we were able to do this 1 patient in Argentina and 3 patients in Europe. And we've seen very advanced patients stay like falling in that stage of advancedness, and the patients stabilize. That's also way more than anecdotal. I have a picture in the presentation, but the computer is different. I can show you later. There may be a role for advanced disease, but the advanced disease part is complex because the problem is even if we hold exactly at that point, we know that it's time. Even if the MRI looks exactly the same, we know that the neurological symptoms are going to come 3 to 6 months after, because that lesion is not showing all its sadness at the time that you're seeing the MRI. I want to say that because the expectation of treating a patient and preventing them from losing walking ability, talking, hearing, vision, maybe not the right one, even for any patient with advanced disease. Because you're still walking and talking, the MRI has a loss of 12, 15, or like 20, like one of the ones that we treat. And even if it stays the same, we know you're going to lose the body. So we have to look at the expectations. So what is the expectation? What are we asking? And these kids are doing better probably than they would do if they weren't treated, but they have lost significant.
Maybe is better than probably, because I think people interpret sometimes as conclusive. So I don't think we can conclude anything. Is that correct to say? Is it fair to say? Okay. Yeah. We're going to be a little careful not to jump to conclusions. All right. Thank you.
Thank you, Ali. So I will close this session with some new aspects on the treatment of adrenal neuropathy or adulthood ALD. We talked quite a lot about very preliminary data in a few patients, but so I'm not going too much into detail, but trying to address some unmet needs in AMN and some possibly targets in AMN that we should address with new treatments. And I will talk about upcoming options without going too much into detail. But I will start with some general aspects of clinical trials. You should know probably, maybe you know, but I just wanted to remind you that it's a great pain to bring just one new drug to licensing, to an approval. So we have to test a lot of compounds until we finally succeed to have one new drug. So it's very costly, it's lengthy, and it's very risky at all. And we also have to include in this process a process we call clinical trials phase 1 to phase 4. So in addition, there may be some, at least in rare diseases, some experiences with unapproved drugs, which we use in individual cases, in small cohorts, and non-randomized studies, which is also very important, at least for rare diseases in some cases. So we have these phases of the clinical trial, which are very important. And as you can see here, we have 4 phases. And in the first phase, it's looking just for safety of the drug. Is there, how is the tolerability of the drug? And some biomarkers, looking for new biomarkers, which then in the phase 2 should be the proof of the concept should be proved. And we are also looking at dose ranges at this period of the clinical studies. And phase 3 is then the large study, usually with many people included in a double-blind, randomized control fashion, so that we now are looking for efficacy of this drug. And if the drug is efficacious, then it will be approved. And then you can enter the phase 4, where there are still some new aspects coming up on the long run. For example, some safety aspects may occur that we not know from the previous studies, which are limited in time. For example, a couple of weeks, 1 or 2 years. But then there may be some safety aspects that occur later on, after 3 or 4 years, that are important. So we need to have a phase 4 to look for these safety aspects. So this is something which is generally very important. And I borrowed this from Ali, actually, from last year. So entering the clinical studies, the first question is somebody eligible for this study? Which also means that the results from the study are only from a certain group of patients, those who are eligible for the study. It's not a real life situation. Yeah. So later on, when the drug is approved, we will give the new drug to a real life situation, which also may include patients that are not eligible for this clinical trial. This is also important to know. Yeah. So then after enrollment, people are randomized to the drug itself. It's the experimental arm, and then we have a control arm. This is done double-blinded. So neither the patient nor the doctor knows if he gets the real thing or just a placebo. And this procedure is mandatory to get approved for a new drug. So there are various steps of evidence, and the quality of evidence is increasing from individual experiences to cohort studies to non-randomized controlled studies up to randomized control studies and systematic reviews or meta-analysis. So this is just to remind you that the whole process to get a new drug into the market is really painful. It takes a couple of years and big efforts and large amounts of money. And the most important is that your patients to be part of this process is crucial. Without this commitment to new studies, we won't have the chance to bring new drugs to the market. So coming to adrenal leukodystrophy, we have heard a lot. I don't want to repeat this, but I just want to remind you that we have two major aspects, at least in adulthood. The first aspect is we have a large group of patients who have a neurodegenerative disease, which is mainly AMN disease with spastic paraparesis, bladder dysfunctions, and so on. We all heard it, and vice versa. There is a group of patients with inflammatory phenotypes. And these two phenotypes are very different looking at the clinical course. Looking at AMN, we are talking about decades, the progression of decades. It's very slow over the years, which would implicate, it has a tremendous implication for clinical trials. So you need longer periods of observation to see differences over time. This also means that these studies are cost more money because you'll have to observe the patients for a longer period of time, versus the cerebral patients who sometimes deteriorate within months. So this is a much quicker progression. And in adrenal leukodystrophy, we have the situation that this chronic progressive degenerative disease is converting to a cerebral disease in up to 60% of the patients in adulthood. So this is another very difficult problem looking at clinical trials. So with this table, I'm trying to summarize what could be the open questions in AMN and adulthood cerebral ALD based on the background of the disease. For example, the inborn error of metabolism, or the oxidative stress, or the energy depletion. We also have axonal degeneration, and in adulthood cerebral, we have this inflammatory problem with a defective innate immunity. It's a microglia dysfunction mainly, and of course, the impaired remyelination. And here are the recent strategies how to address these background situations. And this is the clinical benefit, yes or no. What you can see here from this table is that, for example, for the inborn error of metabolism, where our recent strategy should be to normalize long-chain fatty acids, right? Because you have an inborn error of metabolism that it's high, so you want to normalize it. Well, the strategies that we have there for very long-chain fatty acid normalization, in my eyes, are not inefficient. So we have some efficiency. Don't listen at these lab persons saying we don't have anything. We don't have anything from a clinical point of view. Normalization of long-chain fatty acids is helpful. Point. Yeah. So we have no evidence, not at all, that this treatment, normalization of long-chain fatty acid, is harmful, or is it not efficient. But we have a lot of evidence that it may at least delay the onset of cerebral inflammation. It also may slow clinical progression, at least in adult patients. but we have no proof because we don't have a clinical control trial. And this is a pity, but you can complain about this, but it's a situation. Yeah. So this is why it's not red. We tried to address the oxidative stress with high-dose biotin, no effect. We had a Barcelona cocktail, which is NAC, alpha-lipoic acid, and vitamin A. We see some improvement in biomarkers, but no clinical effect. So, but of course, we have the symptomatic treatments, which are very helpful. So there are treatments out there, a lot of treatments. We talked about some of the treatments today already. So this is extremely important to look what can we do for the symptoms of each individual patient. And there's a lot of symptomatic treatments out there. So there's a lot of things to do. You can normalize long-chain fatty acids. You can have some symptomatic treatments. And we do have something against this defective innate immunity using stem cell therapy currently. At least we talked about these things a lot today. There's a 70 to 80% long-term survival. And it's not only survival, but at least half of these patients are completely stable without any symptoms, without any cognitive decline in long-term observation. So it's a very, very effective and helpful situation. If stem cell therapy is also slowing the myelopathy, is still an open question. I would say yes, but I don't have data yet. I will have the data very soon on that. There is also an effect on the myelopathy. But we have nothing against the demyelination, so nothing to remyelinate, to repair in the brain. There's nothing available. So there's there are a lot of unmet needs present currently. So going through these issues, looking at the inborn error of metabolism, yes, we could ask for some GT treatment to normalize long-chain fatty acids, but there is still a need for control data. But there are two other compounds coming. The one is an AMP kinase activator, and the other is a selective agonist of a ligand for thyroid hormone receptors, which is activating ABCD2. For both of these new molecules, there are upcoming clinical trials this year addressing this problem, the unmet need in correcting this inborn error of metabolism. So this will be something which is available in clinical trials starting this year or early next year. The second unmet need was the recovery of the mitochondria and the oxidative stress. There also will be a new molecule, which is an old molecule actually. There's some experience from the bone marrow people that N-acetylcysteine is a molecule that could be helpful to prevent from oxidative stress. There will be an upcoming clinical trial soon for this molecule as well. We have some data, which is already mentioned today, with lariglutasone, which is a PPR gamma agonist derivate, and we have data on this, and I will probably be able to show you some of the data later on. And there are similar drugs coming up. It's very similar to lariglutasone. It's called a pioglitazone derivate, PXL065. There will be another clinical trial starting, I think, this year. So there are many new molecules starting, addressing the unmet needs in this disease already this year. This is the trial with lariclitazone. You see this is a trial worldwide. There's in the US, Ali, Florian, Yasida. There are many sites in Europe, Mark, Robin Lachman in the UK. There's Maria in Hungary. There's Fanny Mochel in France. In Spain is Josep Gomez and Ettore Salzano in Italy. So it's a worldwide study. And this study in AMN patients using lariclitazone, a new drug, is already finished. So we have results on this study, and the results will be published in the next weeks. They're already sent for publication. So one major endpoint in the study was the so-called 6-minute walking test. So how far can people walk in 6 minutes? The blue ones are always the one with the lariclitazone, and the gray ones are the one who receive placebo. And what you see here, if it's going down, then you're walking slower and not so far. But there is no great difference in the major endpoint. So looking at all patients in this clinical trial, there's no difference if you get lariclitazone or the placebo, unfortunately. Yeah. But this is only true for all patients. If you look, for example, on patients who have a myelopathy or AMN for more than 20 years, that's a big difference than looking at people who have the myelopathy only recently for at least 5 years. So there may be the idea that there is a stage or time-dependent result in lariclitazone. As you can see, the lariclitazone here, the blue ones, are always the same. They're not changing over time. Doesn't matter. So people on lariclitazone in this study all kept stable. They're not progressing. But people who received placebo had different deteriorations. The ones who are very early diseased, less than 5 years, had a stronger deterioration. So there's a big difference here versus the one who had AMN for more than 20 years. So there is the idea that it could be dependent on the stage of the disease. And this brings you up, the idea came up that this treatment probably has some potential for axonal protection. But this is just an hypothesis, but it's based on the data that we have in this study. So the next point is the inflammation. And to stop the inflammation, it's an unmet need in ALD. And as you can see here in this picture is that once you get the patients early, detect the patients very early, and you have a transplantation, you can change the situation, no progression, and keep stable. So this is something that we can do, but we also have some information from lariclitazone. These are preclinical data in experimental animals. And you can see here in this slide that there is a dose-dependent effect on inflammation in this animal model. So the more lariclitazone you give, the less inflammation you would get. So this is interesting, which could be correlating to that what was said previously. And here's the second model, is another animal model. And you can see again that the dose-dependent effect on the microglia dysfunction is present with lariclitazone. So this could be a new idea to use these kind of drugs, PPR gamma agonists like lariclitazone, for treating cerebral patients. And this is also something that we have seen in the advanced study that I mentioned. The red ones are the ones who get these are increasing of inflammation in brain MRI over time. And the red ones are the placebos, and the green ones are the laroxetasone treated patients. And what we are seeing is that we only see an inflammation of the brain during the study in the placebo-treated patients, not in the laroxetasone-treated patients. You might say, well, it's only 2 years. Maybe it's different over longer periods of time or larger groups of patients, but it's still a significant difference within that study that we've seen. So the idea is that maybe laroxetasone has some protective effects on the brain inflammation. So there will be an additional study with laroxetasone, hopefully, in adult cerebral patients that are no longer feasible for treatment with stem cell therapy, starting hopefully this year also. And 2 other molecules, the PXL065, we already mentioned this, and another molecule, they're also addressing this aspect of getting some cerebral brain inflammation. We're starting this year with new clinical trials. So there are some new clinical trials upcoming this year for AMN and adult cerebral patients. And finally, which would be extremely important for all of those who have already some symptoms, who are unable to walk anymore. They want to know, is there a treatment that I can walk again? So is there the chance to remyelinate my defective myelin? So actually, we really don't know if this is working, but at least there is a little bit of an idea, Florian, probably, that a gene therapy for AMN using an intrathecal approach. Intrathecal is that we put a needle in the back part here, in the spinal fluid room, and they put the medication in there. This is a strategy which will be used for the new gene therapy for AMN patient, which hopefully also is in sight, maybe next year, hopefully. Yeah. So this is a new idea, which is not only addressing the progression of the disease, in my eyes, but also maybe some remyelinating potentials of these treatments. So these are a lot of new treatments, and this gives you hopefully a big hope that there is new treatments coming up, but we need, of course, your help to help us to in these clinical trials to find out if these treatments really are working in AMN situation and adult cerebral patients. So thank you very much.
We are already past the lunchtime. I don't want to hold up people all together. So maybe if there are questions, people can just. Yeah. No, it isn't. People can come here and ask the speaker. They don't need to eat. But you don't have to stay. Thank you.